Good morning. I want to welcome everyone to the August Advisory Committee on Heritable Disorders in Newborns and Children in 2024. As we gather here in person at 5600 Fishers Lane, Rockville, Maryland, I want to open the meeting by taking a moment to acknowledge the land we gather on today. We acknowledge that the land and water on which our meeting is taking place was and still is inhabited and cared for by the Susquehannock tribe and the Piscataway peoples, including the Piscataway Konai tribe and Choptico band of the Piscataway Indian Nation. We are grateful for their past and continued stewardship of this land, and we pay our respects to Maryland's indigenous community and their elders, past and present, as well as future generations. We're very excited today to welcome 2 committee members. It also means we're saying farewell to 2 more. But let me start with our new member, Robin Sagatov. I'll get it wrong. See, Sagatov. Dr. Robin Sagatov, finally, enough times. Sagatov will be the new committee member representing the Agency for Healthcare Research and Quality. She's the Senior Advisor for Children's Health in the Division of Priority Populations in the Office of Extramural Research, Education, and Priority Populations at the Agency for Health Research and Quality. She has over 15 years of experience in health research with a focus on maternal and child health. And please help me welcome Dr. Sagatov. So that means we would like to thank Dr. Camilla Minstry from AHRQ for her services and dedication to this advisory committee for almost a decade. And Camilla, I wonder if you would just come up for a moment. This is a HRSA Service Award. And I don't know if you would like to say a couple of words. Thanks.
Sure. Well, I'll miss all of you very, very much. And this meeting has always had a special place in my heart in terms of the work that we do together. We've done a lot and miles to go. So I'll definitely be watching a little bit from afar and also hearing from Robin how everything is going. But welcome, Robin, and thank you all. It's a great opportunity. Thank you.
Robin, I didn't give you a chance to make a comment if you'd like. You have to push the button.
Brett, is it working?
Yes.
Okay. I just want to thank you for welcoming me to this committee. I got to sit in on the last meeting and I was very impressed by all of the information everybody considers for these meetings. So thank you for the opportunity.
We're looking forward to working with you and thanks for being here. Next, I'd like to turn to Jeff Brosco. You're probably familiar with our next new member. He'll be serving as a committee member for the Health Resources and Services Administration. Jeff is a pediatrician and historian who serves as a director for the Division of Services for Children with Special Health Needs, or DSC-HSN, in HRSA's Maternal and Child Health Bureau. He also teaches and practices developmental behavioral pediatrics at the University of Miami, where he contributes to scholarship through UM's Institute for Bioethics and Health Policy. As the DSC SHCN director, Dr. Brosco leads an interdisciplinary team tasked with ensuring that every child in the U.S. receives the services they need to play, go to school, and grow up to be a healthy and productive adult. So welcome, Jeff. Do you have a comment or two to make in your new role?
No.
A man, a few words. That means we would like to just pause and thank Dr. Michael Warren. He's not with us today, but he, has served as the committee member for a number of years, a very valued proponent and supporter of the work of the Advisory Committee on Heritable Disorders in Newborns and Children. He will continue to support us in his role with the secretary and the administrator, and we really do appreciate what he's meant to us. Jeff?
Yeah, this is Jeff Rusk. I just wanted to say a word about Dr. Warren. He has vast responsibility across the entire Maternal Child Health Bureau. And I will tell you, he is deeply, involved in what happens in this committee. When we go to brief him, he's usually briefing us. He's been through every page of the briefing book. He knows exactly what's going on, and he is absolutely going to be continuing to be part of this. So when Debbie and I meet with him, he always wants to know what's happening in the committee. He always has ideas, and he will continue to be very involved.
Thanks, Jeff. We also have a new member in our organizational representative crew, someone who is a familiar face, I think, to many people who work in newborn screening and members of the committee and staff. Amy Gaviglio is a certified genetic counselor and founder of Kinetics Consulting, LLC. It provides newborn screening, public health genomics, and rare disease services in the U.S. and globally. Amy has worked in the newborn screening and rare disease space for the past 17 years. She currently works with the Association of Public Health Laboratories, Expecting Health, RTI International, and several other rare disease and genomic organizations, as well as the CDC. Amy also serves as the chair of the NBS Expert Panel for Clinical and Laboratory Standards Institute and is currently the chair of Minnesota's Rare Disease Advisory Council, and is joining us as a new organizational rep for the National Society of Genetic Counselors. Any comments you'd like to make, Amy?
No, just to say thank you, and I'm honored to be in this role. So thank you.
And again, thanks for making the trip and joining us, and we look forward to your participation. That means we are saying goodbye to Kate Walsh-Folkley, who is, I think there she is. Hi, Kate. She has served as the National Society of Genetic Counselors organizational representative for, I think, more than a decade. And I think she's moving on off the committee to do what in my notes says some more enjoyable things. It's just hard to believe what that might be. Kate, do you have any comments for us today?
My more enjoyable things is I'm planning to retire at the end of the year, so I thought it was time to pass the torch. I have really enjoyed my work with the committee. I especially enjoyed working on the education subcommittee when that existed. I'm really enthusiastic about the work currently being done to include lived experiences in the deliberations about addition of conditions. And I wholeheartedly support Amy's addition to the committee. She's done so much work in newborn screening, and I think will really be a terrific addition. So thank you all. It's been a wonderful experience.
Thanks, Kate. That's all my introductory comments. I'd like to call Letitia Manning to the podium to do a roll call and go over some logistics and point out where everything is.
Thank you, Ned, and welcome everyone to rainy DC in August. It's a lovely time. So we're going to start off with roll call and just acknowledge that you're here when I say your name. Michelle Kajana,
Good morning, I'm here.
Ned Clonge
I am here.
from the Centers for Disease Control and Prevention, Carla Cuthbert.
I'm here.
From the Agency for Healthcare Research and Quality, Robin Sagatoff.
Here, thank you.
Janine Cody,
Here.
Christine Dorley. From the Food and Drug Administration, Paula Capacino.
Good morning. I'm here. I'm virtual today.
From the Health Resources and Services Administration, Jeff Brasco.
Present.
Jennifer Kwan.
Hi, I'm looking at the blank spot where I should be sitting. I am here and I'll be really present in the afternoon.
Thank you. Ash Lau.
Here.
From the National Institute of Health, Melissa Parisi. And Shanika Ponpakul. Okay, and now I'll do a roll call for the organizational representatives. From the American Academy of Family Physicians, Robert Ostrander.
Here.
From the American Academy of Pediatrics, Deborah Friedenberg.
Here.
From the American College of Medical Genetics, Myra Irons.
Here.
From the American College of Obstetricians and Gynecologists, Mara Black. Okay. From the Association of Maternal and Child Health Programs, Sabra Enkner. From the Association of Public Health Laboratories, Susan Tanksley. From the Association of State and Territorial Health, Scott Schoen.
Here.
From the Association of Women's Health, Obstetric and Neonatal Nurses, Katie Swiner, sorry.
Good morning, I'm present. It's Katie Swinier.
Swinier, thank you.
Thank you.
From the Child Neurology Society, Margie Ream. From the Department of Defense, Jacob Hogue.
Here.
From the Genetic Alliance, Natasha Bonham. From the March of Dimes, KJ Hertz. From the National Society of Genetic Counselors, Amy Gaviglio. And from the Society for Inherited Metabolic Disorders, Sue Berry. Okay, thank you. That is roll call. Now I'm just going to go over a few housekeeping items. So according to FACA, which is the Federal Advisory Committee Act, all committee meetings are open to the public. If the public wish to participate in the discussion, the procedures for doing so are published in the Federal Register and/or are announced at the opening of a meeting. And so for this meeting, it was published in the Federal Register. Only with advance approval of the chair or the designated federal official, which is myself, may public participants question committee members or other presenters. Public participants may submit written statements, and we did receive several written comments that were provided to the committee in advance. As a reminder, it is stated in the Federal Register notice as well as the registration website that all written public comments are part of the official meeting record and are shared with committee members. Any further public participation will be solely at the discretion of the chair and the DFO. In regards to ethics and conflicts of interest, I must remind committee members that you must recuse yourself from participation in all particular matters likely to affect the financial interest of any organization with which you serve as an officer, director, trustee, or general partner, unless you are also an employee of the organization or unless you have received a waiver from the Health and Human Services authorizing you to participate. As in the case today, when a vote is scheduled or an activity is proposed and you have a question about a potential conflict of interest, please notify me immediately. So today we are all here in 5600 Fishers Lane. Visitors only have access to the 5th floor. And even though we entered on this floor, it is considered to be the 5th floor. There is a cafeteria across the way here. There are restrooms behind us on both sides and in front of us on both sides of the building. Visitors are not allowed to take videos or photographs in the building. If you need to leave and re-enter, you will be required to go through security screening again. So we really encourage folks not to leave. But if you need to leave, please notify HRSA staff. We're located all around here and someone can escort you in and out of the building. During an evacuation, please exit the conference room and exit out the way you entered. Through that way, you'll see people headed to a parking lot kind of across the way, and that's where we'll wait until we're informed that we can re-enter the building. Okay. For those of you that are joining us virtually, audio will come through your computer. You're able to speak through your computer microphone. If you are unable to access the audio or microphone through your computer or conference line, please use the conference line that was sent to you via email. Also, in order to aid the logistics part of the meeting, when you are speaking virtually, please turn your camera on and use the raised hand feature. If you're having technical difficulties, try reopening the webinar using a different browser. And if you still have technical issues, please refer to the contact information provided in the registration confirmation email that you received previously. Okay, and this is just a screenshot of how to access the closed captions icon through Zoom. And the last thing that I want to go over is many of you are aware that we recently funded a new grant program titled the Cooperative Newborn Screening Systems Priorities Program, or NBS Co-Propel. We provided over $3 million was awarded to states. And this program builds on the Newborn Screening Propel program to ensure all babies receive better screening and care. And it shares the same goals as an NBS Propel program, but it allows states to partner as a region to apply for funding. So this is a map displaying the Propel states as well as the co-Propel states. And the striped states that you see on the map are states that are consortium states. So they receive funding even if it's not direct funding through the consortium. And so we are very excited about this newly awarded grant opportunity. Thank you, Jeff.
Just wanted to remind folks that this is part of the person trying to make sure we fulfill the policy.
Yes. Oh, just grab another mic.
It's Jeff Roscoe. Just wanted to reiterate that this is I think this might become a problem. Oh, that went off too. No, I couldn't. All right. So this is Jeff Brosco. Just wanted to reiterate that the whole idea of the Propel and Co-Propel grants is to make sure that we are fulfilling the promise of newborn screening. And the three objectives of these are to help states with taking on new conditions that we add to the RUSP. They're to help states with the quality indicators for timeliness, and to help states start looking at long-term follow-up and more generally. So it's something this committee has been talking about for over a decade. So we are really thrilled to be working with states and other partners to be trying to make sure that all the things that happen in newborn screening continue through that child's lifespan. So thank you.
Thank you. And now I'm going to turn it back over to Ned.
Thanks, Letitia. So I think we've talked about in previous meetings, I wanted to remind you that the National Academies of Sciences, Engineering, and Medicine is conducting a study examining the current landscape of newborn screening systems and processes. The research will also consider sustainable adoption of screening for new conditions using new technologies. The last open meeting was on May 16th, 2024, and the proceedings of that meeting are accessible online, as well as other past open events. To stay up to date with the study, please use the QR code, which I think is on a slide, 2 slides from now. There it is. And using that, you can go to the website and keep up with it. The other thing I would say is the NASEM website. I'm active with NASEM. It's a wonderful website. You can just put in NASEM and then what you're interested in, and it'll come right up. Next slide, please. I'll just say that the Health Resources and Service Administration's Maternal and Child Health Bureau maintains the Newborn Screening Information Center website. In a future meeting, we'll have a presentation that will provide more details about the NBSIC, and you can use this QR code to find out more as well. but you can see things that we have for both parents and providers, why screening is important, where and how it happens, what happens during the screening process, and then information on how to understand screening results. A lot of people, I think, in this room have contributed information that is summarized in this information. I want to appreciate those other efforts, those other websites, and those other nonprofit organizations that have been doing this work for so long. There'll be ongoing updates to the website, and I encourage you to check it out periodically. I want to pause and just give an update on some condition nominations. Between May and June, we received 2 condition nominations using our new nomination process, which I'm going to discuss in the next presentation. Metachromic leukodystrophy completed the preliminary nomination in May and the full nomination package in June. That's been reviewed, and we will discuss the MLD nomination in depth tomorrow and include a vote. In June, we received a preliminary nomination for biliary atresia. In September, we received a nomination package for biliary atresia with the lead nominator for the application BARE or BARE Inc., which is a national nonprofit organization that supports biliary atresia research and education. You are aware that biliary atresia is a congenital liver disease characterized by the obstruction of the extrahepatic bile ducts and impaired bile flow out of the liver. The nomination and prioritization work group reviewed the preliminary nomination form and determined that it did not meet the full requirements to move on to step 2, which is completion of a full nomination package. Last week, Letitia and I met with the biliary atresia nominators to discuss their nomination, provide some guidance on what we felt was needed to help move it forward, and will be available in an ongoing manner to provide technical assistance as requested. And then during the last meeting, I would remind you at the request of the nominators, the committee paused the evidence review for Duchenne's muscular dystrophy. Moving on to the May 2024 meeting summary, I want to thank the committee members who reviewed the summary and provided additional edits. So we have those comments. We're going to revise those, distribute them tonight, and vote on them to adopt them tomorrow. To kind of give you a roadmap of today, we have presentations on the revised nomination process and the revised decision matrix tool. And I'm going to summarize our prior presentations the committee has had to highlight research that is focused on lived experiences. We'll have a brief presentation and discussion on a method for standardized reporting of newborn outcomes. And after lunch, we'll have our last presentation today related to population-based screenings for newborns and children. Tomorrow, we're going to start the morning with public comments. Then we'll have a presentation from the nomination prioritization work group on metachromic leukodystrophy, and we'll end the meeting with updates from the naming and counting conditions ad hoc topic group. So that's a roadmap of what we're going to try to get through in the next couple of days. And again, I appreciate you being here and your participation. So if we could start by getting up the first set of slides for the nomination and evidence review process. You'll remember that in November 2023, we paused the acceptance of condition nominations while we made revisions to the process. We received feedback from various stakeholder groups during small group listening sessions in November of 2023, and from the rest of the public through a federal registry notice that closed in April of 2024. We had a committee discussion about the process during our May 2024 meeting, and I wanted to take time today to summarize the new nomination and evidence review process. So, to give you some background on how we got to where we are, we know that nominations from different groups and are for consideration to addition to the rest are critical to our work. But we've recognized in talking with the nominators that there's challenges. They have a burden in making compelling and comprehensive cases for adding a condition to the RUSP which requires a tremendous amount of time and effort and resources. We also know that we use a language that's not normally totally accessible to all members of the public. And so trying to figure out how to translate how we talk about evidence and newborn screening in a way that's more approachable was another important issue. So our goal was to simplify the process for nominators and maintain the central role that nominations have for evidence review and our recommendation process. Next slide, please. So we have feedback from groups of 5 recent and current nominations. We've discussed these at 2 previous meetings, the small group listening sessions in November of last year and a large group discussion in January this year. We had input from our former standing work groups, follow-up and treatment, education and training, and laboratory standards and procedures. And then we had public comment, as I said, in response to the Federal Registry request for information between March and April of this year. Next slide. So what we've tried to do, what we have done in terms of making the process simple, is to start with a pre-nomination process. So the condition nomination group would complete the preliminary nomination form, which there's a link to on the slide set and could be found on the advisory committee's website. Consists of the following 4 questions. Is there a newborn screening test available? Is there agreement about the case definition of the targeted condition and diagnostic confirmation after a positive newborn screen? Is there a prospective population-based newborn screening project that has identified at least 1 infant with the condition? And then lastly, can identification of the target condition before clinical presentation allow provision of effective therapy and improve outcomes for screened infants? So those are the 4 questions. If there's a yes to each question and on review by the nomination prioritization work group, there's agreement that yes is the correct answer, the nominators are asked to submit, in addition to that, they're submit 1 to 3 peer-reviewed references for each question with a brief explanation. This helps us understand whether there's enough evidence to move to a full evidence review. But I want to point out it doesn't replace a full nomination package or a full nomination review. So the idea is that we simplify the front end and then provide technical assistance and guidance to the nominators, and then all with the intent of moving them closer to having a packet that might be forwarded to full evidence review. I always like to pause and say, full evidence review doesn't mean that condition will be added to the RUSP. It means there will be a full evidence review that the committee will determine in making its decision. Next slide. So the NNP work group is selected by the committee chair, and it consists of selected committee members. The work group reviews a preliminary nomination form, verifies it meets the 4 requirements to be considered for review, and then the designated federal officer, Colonel Manning, communicates the NNP's findings to the nominators. Nominators are encouraged, Commander, not Colonel. I'm sorry, Commander Manning. I just love saying that, Commander Manning. Nominators are encouraged to meet with the committee chair and DFO to discuss next steps, which may or may not include the completion of the full nomination package. Next slide, please. Once the form is verified by the NNP work group, we then ask for the full package. Those sections include the condition, screening, impact of screening, other considerations not captured in previous categories, and a more extensive set of references. Next slide. The NNP work group then reviews the full nomination package and creates a summary for the committee's assessment, shared with the committee at a committee meeting. Then the committee votes on whether or not to move the condition forward to a full evidence review. So let me just pause and use MLD as an example. First of all, I appreciate the work with MLD in piloting this new process. We learned a lot. there was a good dialogue back and forth with the nominators that helped us do this. So we got the preliminary form, we reviewed it, we chose to move it on to full evidence review. We got the complete package prior to this meeting. The NMP work group has looked through it. We'll do a presentation tomorrow, which we're looking forward to hearing. And at that point, the committee will vote for the next step in the process, which would be to move or not move MLD on to a full evidence review. At that point, the topic goes into full evidence review with our contracted evidence review group, which puts together a technical advisory committee that includes members of the public and advocates for the condition, as well as committee members and other potential experts. We go through a full review that's then presented to this committee, where we make the decision about whether or not to add it to the recommended uniform screening panel. We'll talk a little bit about that, the decision-making step today as well. Next slide. These are just the criteria for a full evidence review. So these are the questions that are included, and these are available to folks, and I don't think I'm going to read through it today. Next slide. So I'm going to pause and just open the floor for discussion from other committee members, other questions and other comments. We'll also take comments from our organizational reps, but I want to start with committee members.
Just this, Jeff Roscoe, just one quick comment. As Ned described, we heard from the 5 previous nominating groups a huge burden for filling out the long nomination form. So the idea of the 2 steps was it's relatively easy to do a quick nomination if you just have the evidence and get back to you quickly. And so you don't have to do the whole thing if there's something that's not going to let you move forward. The concern was, well, if we have a 2-step process, is that going to make it so long that nominators have to go through a lot more work? And I think in the case of MLD, it didn't slow things down. And in fact, we're able from between May and tomorrow to be able to vote on that. So I think this worked about as well as we could hope, but there's always this balance between how much information up front, and just for folks to know that over the last decade, the NMP work group, the NMP advisory group that the chair chooses, there's a lot of back and forth with the nominators. And so this just makes it much simpler and gets to the key point sooner. So far it's working well, but we're open to change, I'm sure.
I like the concept of continual quality improvement. Thanks, Jeff. Ash?
Yeah, thank you. And I do appreciate and I support the change in having a separate nominating vote. I think, to me, apart from the downsides of prolonging the process, but the main upside to me is the preliminary review may identify certain areas that require more focus for the full evidence review package. And that could be tremendously helpful in eventually keeping things in a reasonable time frame, rather than the back and forth that may happen after the evidence review is being done. Thank you.
Thanks, Ash. Christine?
Yeah, so it would be great to hear from the MLD people regarding the use of the form, how they found it to be user-friendly or not user-friendly. And what would be even more beneficial is if you had someone who nominated a condition before with the old process, and then they nominated with the new process, what the difference is and if they found it to be any easier. Just curious.
So great questions. And we actually, we talked with MLD a lot. Thanks, Dean, and everyone who participated in those calls about the process and how we could make it better. There was a little back and forth about the issue about explaining what the evidence is telling us, adding a little bit more comments to help guide the NMP, the preliminary review group. I think MLD is the one condition who had an almost completed nomination package ready to go. So I think that was really good feedback to have. So that's our one group that had both an old process nomination ready to go and the new one. And other than that little, I think the pause plus filling out the form, they were ready to do it because they had all the information on the 4 questions. And we'll have to kind of keep asking people as we go forward. I would say we pilot the process, continue using the process for 1 or 2 more nominations, and then go back and look at the process, see what worked, what didn't work, are we asking the right questions, and then do revisions as we go forward. Let me turn to the organizational reps, and I think I have Natasha first.
Thank you, Natasha Bonham, Genetic Alliance. On the slide that talked about the 4 questions, the third one basically being about finding one child through newborn screening. Is that US based, in a US based newborn screening program, or can it be international?
Thanks for the question, Natasha, and it's not specified, so I would think that either would be acceptable. And if I recall right, we have accepted international
Right.
population base, so
Right.
yeah.
I know it's been a question in the past. That's why I bring it up. So when this is put on the website, will that be clarified? So people
We
know
will
they
clarify
can pull
that. Thanks for that
Okay.
recommendation. Amy?
Yeah, thank you. Amy Gaviglio, National Society of Genetic Counselors. So I think there are potentially in the pre-nomination form 2 areas where further clarifications somewhat akin to what Natasha just mentioned would be helpful. I think the first is the question around whether there's a newborn screening test available. Will the committee examine tests that are either in a non-dried blood spot matrix or point of care? And if so, are there any additional components that need to be addressed by nominators? And then the second is also on the third requirement. And I think given that the achievement of a prospective pilot detection is likely to be one of the limiting factors for most upcoming conditions, it would be good to be much more clear on what exactly this requirement is providing the committee in terms of evidence. And I think saying that it tests the system is just simply not concrete enough, especially understanding that to achieve this requirement, we have historically had to rely on data that has come about from actually circumventing the RUS process. I think we should also acknowledge that a detection of a single case in a single environment on its own really doesn't test the system, as we know that each family's experience with the system is really dependent upon their own individual environment. And so I think if a single detection through a prospective pilot is going to continue to be a foundational requirement for a nomination, I would ask the committee to take the time to reflect on what information that truly provides and really be abundantly clear about that to the public.
Thanks, Amy. And we have in the last 2 meetings extensively discussed this issue. So I think adding a little bit more information about the importance of it could be beneficial to the form. Oh, and your other point was, sorry, what was the first?
Just clarifying whether tests that occur in a non-dried blood spot matrix or point of care, if those would be examined, or if anything further would be needed from nominators nominating a condition using something other than a dried blood spot matrix.
So this is another area of ongoing discussion. Because we're looking at charging states and newborn screening programs, usually laboratories, to do testing, and they don't have strategies for point of care testing. And so trying to decide a route for recommending universal screening for something that doesn't involve a state health department or state laboratory is something that we're actively discussing. We have experience, from the first one from 2011, which I remember very well, which was congenital cyanotic heart disease, which requires an on-site pulse ox. And states have managed to implement that in ways that don't require the laboratory because the laboratories aren't on site. Hearing, of course, started that as well. I think charging the state public health system with figuring that out gives you 50 unique challenges. And so we have started discussions, myself with staff, about thinking about other approaches, especially to point of care studies, because the state laboratories do well, very well, extremely well when they can test with a dried blood spot. Thanks. Other questions? Yeah, Michelle.
Hi, Michelle Kajana, committee member. Following up on that, I think it's really incumbent on the committee and the community as well to come up with a mechanism in order to also influence pediatric care, because the committee is heritable disorders in newborns and children. And so that was used sort of as the argument for some of the other conditions that were point of care. But I think we need to think broader on how to make these recommendations outside of newborn screening as well, and more in the pediatric setting.
I actually know what you're going to say, Jeff, but I'm going to let you say it.
I think what we're both going to say is that's part of what this afternoon is the discussion about, to talk about what are some of the other mechanisms for something being standard of care that are besides a public health laboratory being responsible.
Oh, I'm sorry, Sue.
Thank you, Sue Berry, for the Society for Inherited Metabolic Disorders. We didn't talk about this and it's not included in this, but one element in this that I think has major impact on public health and on the health of the children is access to care for treatment for a screened disorder. So that, for example, if only 6 centers in the US are available to do a specific gene therapy, and that's not going to be widely available in every state, how are children who are on Medicaid in one state going to be accepted for care in another state? And that's a tremendous barrier, a huge source of injustice and lack of equity that we're going to have to address somehow. I don't know if the committee is really in the venue for that, but it's a point of real sadness for me to see that happen.
Jeff, I don't know if you want to make a comment.
I think my comment is that this might be a really good topic for a future discussion, and we can think about who might be good presenters to talk about how it's worked at other places, because surely this is not the first time that a child's needed an out-of-state treatment of some sort. And so learning what states have done, what's been successful might be a good thing for this group to think about.
Scott Schoen online.
Thank you. I wanted to go back to Natasha's comment for clarification on the U.S. population. So historically, and when the recommendation was originally made, I believe that it was prospective data from a population similar to U.S. And I can remember a conversation with Dieter Matern where he acknowledged that he wasn't a demographer, but was pontificating on the proposed population that was being discussed under the nomination. So that's why this is sort of ingrained in my memory. And so what I want to say is that I agree with Natasha that if that position is going to change, that should be clarified quite clearly in where on the committee's notification on this. And so it felt like when you said that no, we'll accept international, that's a little different and not as nuanced as I think the committee has said previously. So I'm not asking you to articulate that now, but I do think it needs to be clarified. If the historic language is being maintained, then that should be clarified. If it's going to be changed a bit, I would appreciate that as well.
Yeah, I appreciate that, Scott. And I think it actually gets to Amy's point as well, that the information that we get from finding a single case is that kind of test of the feasibility and approachability of the system. And so the setting in which it occurs has to provide us with that information. And so that has those nuances about what was the setting. From my standpoint, from the population issue, the other things that could change would be the prevalence or incidence of the condition, which we take into account in other ways. And so I think the issue about understanding how it can be done and can it be done through a newborn screening system similar to that in the United States is the information that's important. And I think we can clarify that. Scott, sorry, Jeff.
Jeff Brosco, and just to clarify more generally that the moving to a two-step nomination process and changing the questions a little bit was not meant to change in any way, shape, or form the criteria, right? It's still the same that we've been doing, but trying to clarify it. So it's not a change in the population or in anything else as far as I can tell.
Deborah?
Stereo mics. So in considering treatment of the conditions that are detected and kind of expanding the thought process about that, I think there needs to be some consideration of the unique conditions that are being identified, but also the extraordinary cost of treatment of these conditions. And, you know, Sue brought up the question of equity is rather large. And, you know, part of what I'm referring to is the cost of gene therapy, which, you know, who bears that burden? Where's that responsibility to make certain that it's equitable and available to all? And also from the pediatrician standpoint, you know, what is going to be their role in expanding the full-scale care of children with these conditions?
Thanks, Deborah. Melissa?
Melissa Parisi, NICHD, NIH. I just had a comment about the recent discussion around ensuring that the one identified individual newborn is actually from a country or a setting that is similar to the US. While I agree that having it be a similar newborn screening setting, I would certainly not expect that the diversity in the United States needs to be replicated in another pilot program in another country. For example, if a condition is more prevalent, because these are usually recessive disorders, in a Scandinavian country or an Asian country, I mean, it would be ideal for those pilots to be done in those countries where they're more likely to pick up an affected individual, given that our bar is so high of expecting at least one identified newborn. So I just wanted to make that point. Thank you.
Thanks. Natasha?
Great, thank you. Natasha Bonham, Genetic Alliance. Kind of building on some of the comments that have been said, when we've spoken to groups who have gone through the nomination process, so often it hasn't necessarily been just the form that has been a lot, but really getting to that point. So really building that evidence, as Amy said, that's really what's been burdensome. And some could say not equitable because different groups have different resources and things like that. So I guess I'm just wondering, thinking of the next phase of this broader conversation of making the nomination, I want to say process, because I don't want it just to be the forms, but, you know, the activity of nominating a condition as accessible as possible. You know, what is the committee thinking in terms of helping, which can mean lots of different things, organizations and groups who want to be able to develop that data and to develop that evidence base? Is it more conversations with NIH, who has oftentimes supported pilots? Is it not seen as within the purview of the committee to think to help, because I can't think of another word, organizations before they get to the point of being able to fill out that form? Just trying to get a better sense of that bigger picture.
Well, I can speak as the chair and less as the committee for this particular issue. I think the committee has the resources it has, and then we have the time to commit to the process that we have, and we have a defined purview. I think moving from our position of evidence receivers, nomination receivers, to evidence creation, I don't currently see within the purview of the committee We do work actually well with both our partners at NIH and CDC. I got to make sure put CDC in there because they've been a good funder and a good partner in the area as well. And they listen and they make contacts as well. We would need to talk, I think, extensively with HRSA and leadership about whether or not we wanted to extend into being more purposeful or a bigger part in that process of evidence creation.
Yeah, and just to add to that, I guess I wouldn't even say necessarily the creation of, but just the support of, which can come in lots of different ways,
Got
which
it.
I do think the committee has done. And
I think we
Yeah.
can do that, yes. Yeah. Appreciate the conversation. We'll take these comments back. We've had some good suggestions about clarification on the form, clarification of the process, and we'll move forward. I appreciate that. And again, it'll be in the meeting notes, but the idea that we might take 2 or 3 conditions through the process and then re-examine it for continued improvement. Not that we won't make changes as we go along, because we learn with every nomination, but make sure that we take an appropriate look after we've done it a couple of times. So at this point, I'd like to move on again to the decision matrix and the next slide set. Hopefully, a lot of this you will have seen before. Next slide. Remember that the matrix tool is to support decision making. It doesn't make decisions. So it's not rote, it's not formulaic. It's supposed to help the committee think through the evidence and support our decision in voting on whether or not to add or not to add a condition to the RUSP. Next slide. Here's the draft that we would like to vote on today. And you've seen it at least twice. There's a top part, which is just a description of the letter grades. There's a letter grade description and action in the middle piece, and then a public health impact assessment at the bottom. The public health impact assessment is required by statute, which is why it appears on the matrix. Next slide. To review the top piece, conditions with A designations will be forwarded to the secretary with a recommendation to add to the RUSP. Conditions with the B designation may be forwarded to the secretary with a recommendation to add to the RUSP after discussion and a separate vote. Conditions with the C designation will not be forwarded to the secretary, but evidence gaps will be identified and shared with the nominators. And conditions with an I designation will not be forwarded to the secretary, but again, gaps will be identified and shared with the nominators. Let me just pause and say if you're a B designation and isn't forwarded, those also will be discussed in terms of evidence gaps with the nominators. Next slide. So turning to the B designation, which is probably the most substantive change to the matrix for the top part, based on assessment of the magnitude of net benefit and the certainty of net benefit, the committee will vote to assign a B designation. There will then be additional discussion of the evidence and assessment of the anticipated impact of adding the condition in terms of individual, family, and public health benefit. So then the committee would take a separate vote on whether to recommend adding the condition to the RUSP. This separates agreement on the evidence from agreement that the condition should be added to the RUSP, and I think will be the source of very vigorous conversations. I want to just review that B rating talks about moderate certainty. And in the certainty world, as you look at grade and you look at USPSTF and AHRQ's process, moderate evidence means that there is a chance that future evidence could come up with a different decision. There's a chance that future evidence will just confirm the certainty. And so that moderate certainty means it's in that kind of gray area where we can't move it into a recommendation based on some kind of gaps in the evidence and uncertainty that future research could fill in one way, moving up to an A, or another, moving it down to a C. Next slide. So we have two areas of judgment: certainty of net benefit and magnitude of net benefit. Again, certainty of net benefit has well-established approaches. When you look at those sources I talked about, they actually talk about the certainty of the evidence in terms of risk of bias, precision, size of the effect, coherence, a lot of criteria that go into the kind of evaluation of clinical trials evidence, and definitely been used in the screening world by the USPSTF and the Canadian Task Force on Preventive Services for a number of years. The magnitude of net benefit is more complex, especially in setting the levels of new benefit. What's substantial net benefit and what's moderate net benefit? And the net benefit means we've considered the harms and the magnitude of the harms in context of the benefits and the magnitude of the benefits. And it's like a virtual subtraction of the two, trying to say that overall we think there's a lot of net benefit or a moderate amount of net benefit. And that is an experiential discussion for the committee as we go forward. And that's why you have votes that are not, all, or that are not unanimous in one direction or another. And it's one of the important reasons why the varying experience of the people on the advisory committee is so important in decision making. Next slide, please. So we've agreed on that matrix, that part, the top part, and now we've been working for the last 3 or 4 meetings on the public health impact assessment. Next slide. This is what we're proposing today from a process standpoint. I want to point out that we want to gain experience with doing this. And so while I'll outline a way to do it as we actually implement it, we may make some tweaks to it going forward. But we would, as the advisory committee, initiate the assessment process when we vote to move a topic to the evidence review group. We would then survey pilot states and take those results to distribute to all other states. The survey should represent the diversity of state population size and overall newborn screening resources so that we have an accurate look of the impact. Next slide. Pilot state survey, next slide, would include current ERG and APHL methods. So we already do this as part of evidence review. APHL has done it for a number of years, and we're going to kind of piggyback on those methods. They will include questions regarding screening, testing, first and higher tier, confirmatory testing, diagnosis, and first-year treatment. Next slide. For every area, the questions will cover whether and what new equipment, staff, and medical expertise was required, with estimates of costs involved, focusing on what we call reasonable ranges. Next slide. So the most important metric is the ease of implementation, and we've had really good discussions that isn't covered by estimating costs. Costs will vary by state, costs will vary by existing relationships and contracts, and that the most important thing is how hard was it to implement. But costs will be useful for other states contemplating screening implementation. What will they need? More than how much it will cost. What access exists to treatment and how it's worked in other states. We still feel cost estimates and opportunity costs are likely to provide useful information as we look at the required level of effort. And we also know that the ERG does use cost estimates in their evidence review and presentation. Next slide. So here's an example of a pilot test report. You see on one side just the testing issues, what equipment, staff, and expertise was needed for first tier and higher tier testing, what expertise and availability was available for diagnosis, and what expertise and availability was required for treatment in the first year. Then an estimate of costs for implementation and ranges, caveats, including comments on opportunity costs, and then pilot results, the total test, positive tests, and confirmed cases. And then finally, I expect there to be a long dialogue about issues in implementation that might be useful for other state laboratories to look at in the next survey. Next slide, please. So the state survey, next slide, asks a series of questions. If the condition is added to the RUSP, what resources or additional support would you need to implement within 2 years? Like external support for startup, regionalization agreements, and others. I had a lot of comments that these will be the same supports and issues as will the next slide that we already know. However, we think this information will be useful to the committee and useful to the secretary as we think about implementation. If you cannot implement within 2 years, what would be the barriers? Are there competing priorities, such as implementing other RUSP additions? Are there other state laboratory priorities? Are there funding, staffing, and policy challenges, and other things that states might identify as being barriers in the first couple of years? Next slide. And then question 3 is, what is your estimate of the effort required for implementation within 3 years? So here's an area where we really want to get experience and we want to talk to state laboratories and flesh out the anchors for making these judgments. So we estimate the required effort will be low. So it could be that low means minimal costs, little or no new equipment or staff or expertise, and the treatment is readily available. We have had a comment from one of our ad hoc topic group members that there will be no easy additions, but we want to put that on the list. We estimate the effort will be moderate. That is, there will be significant costs or new expertise for testing or new equipment or new resources or referrals that will be required. And number 3 was the effort will be high, substantial new investment necessary in staff expertise and or referral resources, and these are unlikely to be available within 2 to 3 years. Next slide. So that's the end of the presentation. This is the complete decision matrix draft that I would like to open for discussion, first with committee members, then with the nomination or with our org rep individuals. And then at the end of that discussion, hopefully move to a vote for adoption, starting with committee members. Christine.
I'll make a comment as far as laboratory is concerned. I think in adding any new RUSP conditions, if they're not FDA approved assays to go along with that, then everyone is going to report from the public health impact assessment that the ability to add will be high from the standpoint of the new FDA regulations and the cost that would be associated with just bringing on a laboratory developed test. So just throwing that out there when we make these decisions to add a disorder, that there be some type of consideration to if the test is FDA approved, that can be readily adopted in the laboratory.
I appreciate that, Christine. And if you have the opportunity to go back and look at the full nomination package, that's one of the questions asked. Is there an FDA approved test? Is there an FDA approved treatment? So those are 2 issues, and I'm glad you brought that up because as we've learned about the implementation now of laboratory developed tests, that there are new challenges and new barriers that will come from that. Thank you. Ash?
I have 2 comments or questions rather. So for the B grade, I think that's, I'm sure is in everybody's mind how that would be adjudicated eventually. So one thing is there could be more than one factor why a vote is a B or assignment is a B. If it is, so is there a subset of conditions that get assigned a B to qualify for an expedited review? That's one consideration. If there is some circumstance or some information that is likely to become available, or so could that be a recommendation instead of having to have a vote on whether or not to recommend? Is so that's one comment. And the second, which is maybe more of a concern for, because we haven't gone through the process, and this potential is the overlap between B and I. When we say that there's insufficient evidence that, or is it a moderate evidence of benefit? I think that the distinctions are not totally clear between the two, and between the low certainty and moderate certainty. And that's the area where, but getting assigned an I seems to have more severe repercussions to the package compared to getting a B. And we would probably have to be very careful as to where in the spectrum we place the certainty level. That's to me is a potential concern, maybe not having gone through the process.
Thanks for your comment. I actually think they're related. So the idea is that if the judgment, because these are judgments, so you're at that B level, and the judgment is that it's uncertain. Uncertainty comes from having an evidence gap. And so if it's an evidence gap that could be filled in by within a year by researchers or the nominators, then that would be a candidate for an expedited review, which is a decision that the committee could make. So I think those are, we don't specify that in the matrix, and maybe we could include that in the kind of notes that if you get a B, that would be a candidate. Because if you're a B and you move to a C, that's different. That means pretty sure that this isn't going to come up to the, so that actually is a little bit worse. If you go down to an I, it means there's an evidence gap and we're just uncertain. So I think we can make that. And then perhaps what I should do is kind of provide at least the reading list, and then maybe even a presentation on the assessment of certainty. And we can do that because there's a lot written about it. Remember that word judgment. I always come back to this. People can look at the same body of evidence and make a different decision on certainty. And that's why, as I said, votes are rarely unanimous, but not never. And it really has that, do you feel that the evidence meets all of these criteria in a satisfactory way? I think the task force's levels are convincing, satisfactory, and unsatisfactory. So there's a whole process for that certainty, but it ends up with a judgment looking at the evidence. So we'll provide that information, and we'll do a presentation if that's okay at our next meeting. I think, Melissa, I think you're next.
Melissa Parisi, NIH. So I guess I'm a little bit uncertain, and I think I might have raised this at a prior meeting as well. Who is making the determination of these B and C, A, B, and C, and I? This is the ERG?
No, this is us. This is our discussion.
But so does that mean then that, I mean, you said that all Bs would be discussed, but it sounds like it implied that there was not going to be discussion of a C designation. Do you want to clarify? I mean, I guess the process is a little unclear.
If we say a C, That's at least moderate certainty of zero small or net benefit. That's a decision we would make. We would assign the C.
May I jump in?
Yeah,
So
please
part of the
clarify.
confusion, I think, is that if you look at our current decision matrix, a B does not go to the RUSP, does not get recommended. And that has not been our what we've been doing. It's not been our practice for the last 10 years. So this idea, there's a discussion about all of them. We discuss all of these, but an A grade is, yes, we're recommending. It's A equals, we recommend to the secretary. In the past, what our decision matrix said was a B or C, we don't. And yet this committee has fairly often said a B, yes or no. So what we've done, we haven't changed the criteria per se. We've just updated it to match what we've been doing the last 10 years. So there's a discussion about all of these. This is graded by this group, but a B may or may not be recommended to the secretary for inclusion in the RUSP.
Okay. And I guess kind of as a follow on to that, I think it might be worth clarifying that because when you just read through the slides, it sort of, that did not come through, that there was actually discussion around A, B, C, and I. And then just, a final thought, which I know I've made this point before, I think there's a big difference between a negative magnitude of net benefit, which is actually a harm, and zero or small. And small, of course, as you just said, Dr. Collage, it's very much a judgment call in terms of the survival of a child. For some individuals is a significant net benefit. Some other people might think of it as small. And so the lumping of zero, small, or negative into that C category is still somewhat problematic, for me at least. Thank you.
Yeah, there is another category called a D, and for simplicity's sake, I figured that we should drop it off because if it's so small, if it's more than small, then we're going to put it in a B, and that'll be a judgment call. And trying to figure out that cutoff is difficult. So I wanted to have it be discussion. We could expand it, and I guess my recommendation is we not, unless it becomes a problem, and I'm uncertain it'll become a problem. But I understand your issue. I thought about it a long time. I think currently the USPSTF gives those Cs as well, but a D goes to the absolute harms, and so we just kind of collapsed them. Michelle?
Michelle Kajana. Just a couple comments. So I thought in the past, after the evidence review makes their presentation, that they do put up this matrix with a suggestion. So that process will continue, and then we will discuss and come up with sort of the final designation. Is that what you're seeing as the process?
Yes.
Okay. Just wanted to
Jeff,
clarify. I
sorry.
wanted to clarify. Sorry.
Can I just clarify that for a second?
Yeah.
So the ERG makes a presentation on the evidence.
Mhm.
The committee members who are liaisons to the ERG, they're the ones that make the recommendation about A, B, or C, or I. So the ERG is not making recommendations about this.
Okay.
It's the committee members who are liaisons that make a recommendation.
Yeah.
And it's
but-
their recommendation, but then the committee votes on it.
Yeah. Okay. Because in the past, I thought that they did show the matrix at the end of their presentation.
No, they
So
do show the matrix, but I just want to be clear that the recommendation's not
Right.
coming from the ERG.
Right.
That's all.
Yes. Okay. And then so I think the B is we're just gonna have to try it out and see how it works and how we discuss it. And then the last clarification was going back to Dr. Dorley. On the nomination package, the issue about an FDA approved test is really talking about the confirmatory and diagnostic, but not necessarily the screening test, which is what the newborn screening programs will be, will have to, answer to. And so I think it is kind of important that we make sure we make that distinction during the nomination and understand that that's going to be a tough piece of this as we go forward for the public health assessment as well.
Thanks, Michelle. Ash?
Just wanted to follow up on so looking at the distinction between C and I is whether it's a question of certainty or whether it's a question of magnitude of benefit. If I get the sense of the categories here. So following up on the comment that if we want to avoid negative language, the C category could be at least moderate certainty of less than moderate benefit. It could be reframed in some way. But that's probably what we're trying to say is that we're moderately certain that the benefit is not even moderate. It's less than moderate. But we don't, so that could be either small or it could be zero, it could be negative. But one could consider just changing the language so it doesn't come across like that. And the I is then not about the magnitude, but it's about certainty.
Yeah, I understand what you're saying. I get it. Shanika?
So for the public health impact assessment, for the public health impact assessment, the lower table, I think it's great that we put it up there. From what I recall from Dr. Talali's presentation, that number is very high, that most states can't implement it in 2 years. And perhaps that would be something that, you know, people can use that as what can we do to make sure that that can happen, or resources for them to help. Because I feel that, you know, 2 years is a very short time for most laboratory to implement anything that's recommended. But I'm not in the lab, so I don't know how you feel about it.
So I appreciate that comment. If you go back and look, I think at the second question, it's like, you know, the first and second questions are, you know, what are you going to need and what are the barriers to get there? The 2 years we went back and forth in, and was actually based on the median in states that have alignment laws. So that's where we got the 2 years from. So for those states, we were trying to make sure those states had a voice in saying, can we do this in our alignment law issue? Because I thought that'd be important. And Ash, I like your suggestion. I have no issues unless the committee does in changing that to at least moderate certainty of less than moderate net benefit. Okay. Melissa.
So I have a question about the public health impact assessment. It feels to me like just having those 3 categories does not capture the nuance of what may exist for many of the states. And so also like Shanika, I was concerned about the 2 years. I'm wondering if there's also the option of asking 5 years, 2 years and 5 years. I know that's a little bit of trying to, you know, anticipate the crystal ball, but it feels to me like that's a little more realistic in terms of what some states are capable of. Oh, I'm sure Jeff will have something to say about that. But then really my question is, it seems like the effort required is going to vary depending on whether a state has received funding to support addition of new conditions, either through some of the HRSA funded Propel and Co-Propel grants or some of our NIH funded pilot studies. And that's not captured in this kind of simplified chart. And in addition, you know, it just seems like there's so much more nuance around whether or not a state also has RUSP alignment legislation that is dictating that once something gets added to the RUSP, they are required to bring it on within a certain period of time. So I just wonder whether having these gross percentages is really going to be meaningful, given the fact that there are so many nuances that underlie a state's ability to make a public health impact assessment. Those are my thoughts.
Pretty much putting anything on the matrix is tough. And clearly the B1, B2, A1, A2 didn't work. And so we are trying to think of something to meet the statute that might actually be something that the committee could look at. Not that we would say, or we might, if 48 states say there's no way we can do this within 2 years, that may be something that we would want to consider before we voted on starting the clock, especially for states with alignment. And it won't be the only information that we have. We'll have the answers to the other questions. But in terms of putting it on one page and having a matrix that meets the requirement of the statute. This is what we, after 3 meetings of trying to figure out what we could put on the matrix, this is what we thought would be best. Jeff, I'm sorry.
Yeah. No, just to say that you're absolutely right, Melissa. And as Ned said, we've had multiple work group meetings with laboratorians and follow-up folks, and just there's not a way to do this easily, but it needs to be there. And you'll notice it's a switch. Before it said, how many years will it take? And the response was, well, it often depends on how much resources I have. And so given the RUSP alignment legislation and saying, this needs to be done in 18 months, 2 years, 3 years, we chose 2 for the reasons Ned said. And I'll just give you an example. Imagine it's 2019. And I said to you, how many years will it take to develop a messenger RNA vaccine and get it to every single person in the United States? You'd say 10 years, 15 years. If you said 9 months, you'd say, well, that's absurd. There's no way you can do that in 9 months. And yet, if you put enough resources into something, you can. So the idea was to sort of flip the question around and say, well, if we had to do this in 2 years, what would it take? And there are, what we've learned from our friends is there's 50 different answers. And this is not meant to be you're not meant to remove information. The committee would still have a lot of information about stuff and a lot of discussion. How much it helps the committee make a decision about something, you're right, is probably not the most important thing.
Could I just suggest then adding the number of states that were part of the survey process so that we understand what the denominator was?
You bet. And I get back to that issue. We want 100%. That's our goal, and at least be representative of the spectrum of states from a resources and capability standpoint. Yeah. Janine?
Janine Cody, committee member. Sort of back to the resources thought. Now that you've sort of been through this new multi-step process, is there capacity among the staff here to do this on an ongoing basis? Or have we slowed down the process because there's not enough capacity on the HRSA staff side to really accomplish these goals?
So I think it's important to point out that Ned presented a way of doing this, surveying the pilot states and then surveying all the other states. Right. So just to say that how that actually happens, you're right, is going to depend to some degree on HRSA resources and a whole bunch of other things. OMB will say you can't survey more than 9 people without an OMB requirement. So a lot of things have to be figured out in the process. The key thing for the committee is to vote on whether this overall concept, how much is required, what are the resources necessary to implement in 2 years. That's what the committee needs to sort of focus on. But maybe I missed your question.
Well, that was part of the question, but the other part was this whole thing. Now that we've been through this multi-step process with MLD, I mean, did that put a huge burden on the staff here that if there's multiple conditions coming through, does the process slow it down for the groups?
The rate limiting step for that is really the evidence review and what the resources are available for the evidence review group. So I think our team's strong. We're good.
It put additional strain on the chair. But
that's apparent, actually.
That's why I get the big bucks. I think the other thing I would have to say, Melissa, is that we reached the bottom part of the matrix that was the least objectionable to all of our stakeholders from the state laboratories. So that was it was interesting. We did not come up with what's perfect, but we came up with something that we could say, this might be useful and we think we can get this information. And now we'll see. Let me turn to our organizational reps. Oh, Michelle, I'm sorry.
That's okay. Commenting on what Dr. Parisi said, I think another thing that might be helpful in the discussion, not necessarily in the matrix, but when we're thinking about this, is not only the N of states that responded, but the number of babies that will be covered by those responding states as well. So you get an assessment on the impact across the entire country. So maybe as part of this, we could capture that as well.
Great. I like that. I apologize, I don't know the order, so I'm just gonna go. I'm gonna start with A.
Thank you, Amy Gaviglio, National Society of Genetic Counselors. So the public health impact assessment process seems to hinge on there being a universal pilot state within the US. And I wonder what the plan will be in the absence of such a US-based pilot. And then, I'm sorry. Oh, and then I also wanted to affirm what Dr. Kajana said with the new nomination. There are actually no questions that are explicit around FDA approved kits for screening, diagnostic tests, or treatment. And so if that's going to be something taken into account, that should be added.
Sorry, Jeff, you.
So I think that is in what we're going to do is add that to the notes for the second step of the nomination process. I think that's going back to our previous discussion.
Great question about our ability to survey international programs, and we're just going to have to try it. Thanks. Natasha.
Natasha Bonham, Genetic Alliance. I have a couple of comments or questions. So first, in regards to the public health impact assessment, I would encourage a renaming of that to public health lab or public health lab and program assessment, because that is where the deep dive is done and not on all the other components of public health around newborn screening. In terms of, we're not screening just to screen, but really looking at that, the impact on the child and family, which I know we'll talk about later on. There's no inquiry into the cost of from the maternal and child health system beyond the program, which I'm not saying we should. I'm just kind of highlighting that it's not public health. It's really, Jeff, you're looking at me super confused. So hopefully I'm making sense to someone in here. So it's just clarifying that labeling of it that I just encourage as someone who likes to get as much clarity as possible. Next is really building on what Dr. Parisi and Dr. Kajana mentioned. We always know different states have different means, but I think it's over 20% of states have some type of RUS alignment legislation that does come with some varying form of fee structures and things like that. And I also believe that actually covers 50% of the babies born. So it is a large portion. And so I think having those denominators when we are having the discussion would be really helpful in the survey. And lastly, I also appreciated Dr. Parisi's comments about splitting C. When this information goes back to patient advocacy organizations and the researchers doing this work, they really do take the words of this committee seriously and strongly. So having that sense of the difference between, least moderate to negative net benefit, I think could have a real impact on those groups. Thank you.
Thanks, Natasha. Sue?
Sue Berry for the SIMD. I'm coming back to the public health impact, which is sort of down at the bottom and sort of, I understand why it fits the way it does, but one of the things you mentioned in there was to have states assess the impact of follow-up and treatment. And I'm uncertain that states really have a great handle on the impact of long-term follow-up and that they really have access to the complexity and details that are going to be involved in treatment. I know that when we've gotten sort of this we've had surveys like this, and in my state, they always turn to me and say, well, what do you think? And I go, well, who's going to pay for the transplant? Things like that. And that it's going to be difficult for states, particularly larger states, to be able to get a fair assessment of that, and for smaller states to even know if the resources exist. And so I'm not sure how that impacts your decision, your overall decision, which I think we should pay more attention to. So dropping the same question out to you again. Thanks.
Yeah, it's a great point. I only know how we do it in Colorado. We have close links between our state laboratory newborn screening program and the Children's Hospital. So when we were looking at adding CRAB-A, which even though I'm in the state health department, the lab never asked me about, they just asked children's. It was independent. They were watching the committee's work going forward and starting to explore already what we would need to do. They did the same thing with psychosine. We can't do psychosine. We're going to have to figure out how to do that regionally before we implement it. And those are things we have to work through. So they're already thinking, but they think, at least our folks think all the way through the process and capitalize on existing relationships. In a large state where there are multiple centers, I think there'll be other challenges. But Michelle, you worked through this in what I think is a not large geographically, but huge from a population standpoint. And kind of wonder if you think these are questions that your colleagues in other large states can answer.
I think a lot of it depends on what their experience is and how they've actually carried it out. Different states have different mechanisms for funding and whether there's a fee structure or not. Whenever we want to add a new condition to our panel, we reach out to our specialists and say, what do you think about this? And make sure that we have their input and buy-in before we actually do move forward. But I think the questions that are on that the pilot survey state are pretty answerable for the states that have the experience. It might be, and I think if states know, I think we had this discussion, but I think if states sort of know what they might need, they kind of can understand what it's going to take. I think maybe instead of issues for implementation, it might be considerations for implementation, that one category. And, you know, based on our experience and how we do things, which we share with people, you can sort of get an idea of what you're going to need in your situation. So I think it's
corollary
doable.
to all of this is it assumes that that somebody's going to pay for all of this and that they will know how that happens. And I would assert that that is a very difficult thing to determine.
I know that's true. And I think one of the issues you already brought, one of the issues was transplant. And if I'm in a state that doesn't have a transplant center and my Medicaid program doesn't pay for care given in another state, then we're not providing the benefit of newborn screening. We're providing a lot more challenges. Yeah. Michelle.
When we began CRE-based screening, and I know this was going back a ways, but we put in considerable effort to make sure that our Medicaid folks in DOH knew what the situation was going to be and that these kids may have to go outside of the state for transplants. And so it's necessary for the state for the program or their chain of command to figure out how to make that work and make sure that they have buy-in from their Medicaid providers within the health department so that it's possible and those kids don't have to wait. And so we actually did a considerable effort to make sure everybody was on board with that. So it is possible. It's a lot of work, but it's possible.
And you're New York and gene therapies are not going to be done in more than 3 or 4 places. Right, exactly.
Margie.
Margie Ream, Child Neurology Society. I think my question also picks up on the theme that we've had the last few questions. Can you clarify what's meant by referral resources? So that was on your last slide with kind of detail about the public health impact. So referral resources, is that just for diagnostic confirmation or is that for treatment? And if the process may be, you suggested that maybe the committee would consider the effort involved before recommending addition to the RUSP. If a treatment is not readily accessible, whether it's because of geographic location of that treatment or cost, you know, how does that play into kind of what you had said about if there's high effort required, particularly for the RUSP alignment states, maybe that would be part of the consideration of the timing of recommendation.
First to your first part, we were mainly thinking about treatment referrals. There is a section in there on diagnostic testing, and we can certainly add referral resources for that as well. I think the issue about availability of treatment is an ongoing one that the committee won't be on the form, but all of that information should be in the background whenever we look at adding something to the RUSP. And thinking about timing, I think, is important. And it's a consideration that I think we need to continue to bring forward into our discussion. Remember, this is a tool to help us make decisions. And it's not an easy decision. It's not, that's why I try to stress that the matrix doesn't make the decision for you. You make the decision, and the matrix is a tool designed to help us get through that. It's the same way I look at negative, like a net harm. You may get a C, but to Natasha's point, the information back to the nominators will be, this looks like it does more harm than good. It's pretty direct language. And so we won't, the matrix doesn't define the letter. It's something to help us make a decision whether to add or not add. And there are nuances that we bring up for every part of it, other than it would be nice to have a few more high certainty of substantial net benefits, because those are a little bit easier. Oh, that could be easy to implement. So the home run of newborn screening, it probably is rare. So I appreciate the question. Go ahead.
I think that, if access, like kind of like what Sue was saying, if access to care, whether it's financial or logistical, access to care is identified as a big barrier, what can the committee do to advocate through other avenues to reduce that barrier?
Putting on my hat as the director of the Children with Special Healthcare Needs section. So that is something that we are actively working on, and we can even do, you'll remember 2 years ago, we had a presentation on the Blueprint for Change for Children with Special Healthcare Needs. So clearly the population of kids identified in newborn screening fits into that. So HRSA is working with all of our federal partners to try to make sure that if a treatment is necessary, that it's available to every child.
All great questions. And it gets to the equity issue as well.
Do you mind if I ask a question?
Yes, Jennifer, please.
So I think this conversation about the availability of treatment is really terrific. And not that I think it necessarily belongs on the matrix, but I think what I'm hearing from a variety of speakers is that it belongs somewhere, right? So we have the evidence review, we have a comment from APHL about the lab's capacity, estimated capacity, but we don't really have a discussion about treatment and the availability of treatment. And I didn't know if what I'm hearing from people is a desire to have a more robust discussion and review of that. What do you think?
I think that is what you're hearing. And again, I think there's a question in the full nomination package that addresses that, but it may be that it's something we need to address more specifically and make sure that when we're looking at a nomination package, and maybe even I don't have the ability to say what should be in the contract with ERG, but it may be that we could look at our partners who do evidence reviews and assessments and figure out a way to make sure we have a complete an assessment of the availability of what's going to be needed to provide services for the kids identified is really important. If you remember the Wilson-Young criteria, which of course I know very well, one of the criteria is that adequate resources exist to provide treatment to those identified with the screening test. And if you fail that, Wilson and Young would say, don't screen for it. It's a hard concept for a lot of folks, especially advocates, to grasp. But as a public healthcare system, it's like, what have I done that's beneficial to identify someone who then cannot get treatment? And there may be benefits that many people adhere to and feel are important, but it's just part of the screening test criteria, and I think it's an important point.
And did I not hear Jeff Brasco volunteer HRSA as maybe the group that could provide evidence of treatment availability?
Can we go back a couple slides? Because I think we missed this in the discussion. If you go back to the slide that says, go back again. The other way, the other direction. The one that's, what's the title of the slide? Highlight. Go back one, another one, please. One more. Stop there. So look in the bottom left-hand corner, follow-up treatment expertise availability. So in the example that we've given of what the kinds of information that would be asked, this is clearly included. Can you go forward 2 more slides again to the anchors? One more. And it's not as explicit here, but in Margie, you asked this question. So treatment readily available is for low. We have this new source for referrals. Referral includes treatment. So I think we tried to put this into both the anchors and the overall survey. That's why I was frowning when you made your comment before, Natasha, because I thought we tried to include this as really a public health assessment and not a narrow laboratory or follow-up program one. Getting the information is hard. It varies across states. There's all sorts of issues. But to the degree that the committee can gather information and have it at their disposal, it can be part of the decision-making process.
Sabra.
Thanks. Sabra Ankner from the Association for Maternal and Child Health Programs. So kind of coalescing what I think a lot of folks here have said, but I do want to just say from the start, when just specifically talking about readiness of state programs, there's really got to be a do you have a lab or not? I think that's been a problem for a while, that they're, asking a state that does not have their own lab about their readiness is just profoundly different than asking a state with a lab. The way, they first, I need the lab I contract with to be able to do this test. Then, right? And so that has, I used to fill out that survey, and that was the problem that I had. Like, I don't know, not in charge of that part. I can tell you about our specialist availability. I can tell you about the other things, but I'm not actually in control of the lab piece. And so I think really having a way for folks to delineate that, it's not the biggest percentage of the population, right? If we're basing it on that are going to be those jurisdictions, but it is often the jurisdictions that are going to have the biggest barriers in basically every other piece. So I think that part is really important. The other thing is, I agree with these guys that have said this already. What is being listed here as the public health impact assessment is not. It is a public health lab and program assessment. I pulled up CDC's definition of health impact assessment, which is helps evaluate the potential effects of a plan, project, or policy before it is built or implemented, and can provide recommendations to increase positive health outcomes and minimize adverse health outcomes. In that context, this whole thing is the public health impact assessment, right? So I feel like we're getting stuck on the term that is in the statute, which again just says include an evaluation of the potential public health impact, including the cost of such expansion, which again doesn't say anywhere in there just at the state lab, right? It's broader than that. I think that this is, even just if you're talking about the public health state agencies, is this, newborn screening is a small part of what public health state agencies do and what they have to account for and what they have to go to their legislatures and ask for funding for, including in the maternal child health space. And so I really think that really trying to better ascertain if that's what we're doing, if we're really including this percentage of states reporting and their effort because we feel like that's what makes it compliant with the statute. I don't know that that's, again, I think this whole thing is a public health impact assessment. But I think that also really thinking about what the cost of treatment are, the availability of treatment, of diagnostic testing, and the harms of all of these things, because they do exist, is really crucial. And what the reality is that if we are paying for one thing, we are not paying for something else. Do we wish that those decisions were made differently? Yeah, but they aren't, right? And so we are working from one pot of money, and that really is the reality for public health agencies. And I think that it would do us well to have a better understanding and appreciation of that.
I appreciate the comments. part of the understanding of the use of the words comes from where this came from, which was congenital cyanotic heart disease, which is a point of service test that state labs couldn't do. And because the recommendation came to add it to the RUSP, it ended up in a lot of activity. And one of the activities is we should be able to talk about whether or not states are ready or able, or is it feasible for them to do this testing? So given that's where it came from, that's why it's restricted to kind of state screening programs as terms of the assessment. But as Jeff said, we're trying to be inclusive of those other elements of treatment and diagnoses. So given where it came from, I think, and that we have to do some assessment about, sorry, the other piece is the understanding that not all states have implemented all conditions. And for a lot of the reasons people have talked about, trying to bring that into consideration and better identify matching of resources with the intent, which I came in as chair hoping to further and have had little, if any, success, is that all 50 states should screen for all of the conditions that are approved by this committee. And we're not there. And so thinking about the assessment and how that can be used to argue and promote and advocate for resources to meet that need, that shouldn't we do the ones we've already approved in all 50 states? Shouldn't that be a priority? I think that's kind of where I'm at with the assessment issues. And how can we get people, how can we help states to get there? What is the role of HRSA and other federal funding to get us to at least that point? There will be new conditions. We're in the middle of considering new conditions now that will add to the list of things like a small or a less resource state isn't doing. And have we helped the children being born in that state? Have we helped people in that state? I'm uncertain. So I understand that this is looking at the benefits to the children, the potential harms, all of the other issues as an entire impact. This section is just, are we ready? Are we able? And we could have used those words, feasibility and readiness. I think those were the terms in the original set. And we wanted to kind of meet what the statutory wording was.
And I think it would also behoove us to look at not just is everybody screening, but are they screening well? And are the outcomes improved? Because that we, you know, if every jurisdiction is screening for every RUSP condition, but there are some kids who are still never getting treatment, never getting care, never getting appropriate care, which we know is the case already for the conditions that are universally screened for in theory, right? That we, you know, and so it's, what are we asking folks to do? Because we're not doing the things we say we're doing well yet.
Yep. Thanks. Deborah.
Hi, Debbie Friedenberg, AAP. And I think there's kind of been a little bit of a diversity. You know, there's been a theme in terms of follow-up and treatment and the readiness within states versus the laboratory's ability to actually perform things. And one of the things that I, you know, as I was listening to this, that I was thinking about is that it's very hard for treatment and follow-up for a state to really get a good handle on that, as hard as they try. And even in states that think they have good relationships, you know, when you have not one particular specialty center, but you're dealing with 8 or 9 of them across a large state, that sometimes there's going to be a diversity of opinion in those states. So you may never come to consensus on what people think would be the best way to approach it. And I just thought that should be part of our consciousness in thinking about this.
Thanks, Deborah. Michelle?
Just a couple of comments. I think when we're talking about help with implementation, I think we should remember that we have advocates that can help us with some of this work and getting things on board. The other thing I would mention is that the community itself is working through CDC and others to create centers of excellence to help with some of the the efforts of states that may not be able to bring on board either the initial or higher tier testing. And so there is activity to help us within the newborn screening, at least lab community. And the last thing is this whole discussion about follow-up and availability and expertise from the pilot states, and I don't want to say it, but I will, stems on the N of one rule, right? Because we're not going to be able to do any kind of assessment unless we have a pilot study within the state that you're surveying who finds a baby and then sees whether or not they're available for treatment, whether treatment's available to them. And I think that's important to kind of keep in mind. The last thing we want to do is identify a child and then say, sorry, we have nothing for you. That's probably just as bad as having a diagnosis when you're not screened, to say we know what you have and we can't do anything for you. So thanks.
Susan.
Susan Tanksley, Association of Public Health Laboratories. So I wanted to follow up on a few of the comments that have been made, and I appreciate so many of the comments that have been made today. Regarding how do you gather the information on treatment availability and expertise in states? And Dr. Friedenberg just mentioned that there may be differing opinion across the state, and we found that when we did the public health system impact assessments and tried to gather information from specialists within our own state, and would literally get complete opposite ends of the spectrum. And then as a program, how do you respond to that ABC response in the survey? And they average each other out. And so I'm wondering if there's a way to gather information. Alex will love me for this, I'm sure, during the evidence review process, so we have a technical expert panel, but typically that's people who are on the nominating, part of the nomination packet, the experts who have helped put together the information for the nomination, but it really doesn't represent specialists in the field from a more diverse perspective. And so I'm just wondering if if that might be a way to gather some of that information from throughout the nation. So that's one comment I have. And then the other piece is that we know from history that the public health impact assessment has really not been taken into as a factor in the vote. And so feeling that will probably still be the way forward, will the information gathered from the public health impact assessment, like how will it be used? Will it be used to try to develop funding, to develop ways to fill those gaps, those sorts of things from a national perspective versus each state trying to figure out how to fill those gaps? Thank you.
Thank you, Susan. And that is certainly the intent. I think also with this discussion, while I talked about the assessment being separate from the decision, I think thinking about timing of implementation and voting might be something that's within the purview of the committee to think about when we have a condition that's implementation seems far out of reach without additional resources. Appreciate that. Scott Schoen.
I'm good.
Hard to believe. Carla?
Can't follow that one. Carla Cuthbert, CDC. So Susan, thank you for your comments there. When we were reviewing this slide deck, we wrestled with the idea and the thought again that yes, there are some things that we don't factor in necessarily when we're thinking about the vote, and the public health impact seems to be one of them. And we recognize that it takes a considerable amount of effort for all of the states to fill this out. And it may even feel a little disheartening when you go through this entire process, you pour your heart out, and you try to resolve this, put it down there, and it feels like there's nothing. But I think that what we understand, again, apart from it being required, is that it does provide us as feds, and I speak for ourselves, it provides us with a bit of information as to what can we do to position ourselves to help, and being able to understand what some of the barriers are. They're going to be different for each state, and Melissa brought this up as well earlier. It's that everything is so nuanced. It's you may have a condition for well, we don't have another set of instruments. We would need more space. We would need all of these other things. But being able to have this information available, even if it's not factored into the vote itself, helps the feds to be able to consider how to mobilize to be able to address it. And it may not be an immediate flick of the switch that, hey, you need money, we got money. But it does get us geared to try to figure out how can we really help. And this is something that has sort of motivated us to the Center of Excellence idea. This was something that, again, we thought about for several years, and provides us with an opportunity to evaluate this particular idea. And I know that the states have thought through this as well as a possible solution. Our program at CDC is we really are moving forward with technical assists as well, where we have a group of laboratorians. Again, this is from a laboratory perspective. I recognize it doesn't solve all of the problems. To be able to just send our staff out there to be able to work through issues, help with the implementation, and be able to get over that hurdle. So it does allow us to try to figure out how are we going to do this and how can we help. So I hope that's helpful. We do, like I said, we do recognize that it takes a lot of effort, but it's not for naught. I just want the states to hear that specifically.
Thanks, Carla. So moving on. Before we entertain a motion, I want to tell you what you're voting on. So you'll be voting on the adoption of the matrix. Oh, let me just pause and say, we've used one slide to discuss almost all of the challenges of newborn screening, which cannot be fixed with a single slide. So I appreciate all the comments and a lot of rich discussion and things that we will continue to talk about and work with our federal partners, our clinical partners, and our state partners and other advocates. The revisions that I think that we agreed on was the C, we'll say at least moderate certainty of less than moderate net benefit. That's one change. The second, well, the public health assessment for implementation in 2 years will include the number of states that completed the survey question. There are other caveats that we will add to notes in supporting the matrix, and we will keep in mind we may need to modify and add another category in the future, depending on experience. But with those two caveats, I'd like to make a motion if it could come up with the next slide. Is there a slide, a motion slide?
I'll move.
Okay, Shanika. Go ahead.
I'll move to move forward.
Adopt the
The
decision matrix with
decision matrix.
the changes discussed.
Okay, with the decision. That is me, sorry. Yeah. Okay.
Just maybe the next slide. We'll fix it. You understand that it's where that goes. The
Go to
phrase
C.
down. Yeah. Is there a second?
I'll second.
Thank you, Ash. Could I have a roll call vote, please, Letitia?
Just say yes if you agree with the motion. Michelle Kajana,
Yes.
Carla Cuthbert,
Yes.
Janine Cody,
Yes.
Robin Sagatov,
Yes.
Christine Dorley,
Yes.
Paula Cappuccino,
Yes.
Jeff Brosco,
Yes.
Jennifer Kwan,
Yes.
Shanika Pampakul,
Yes.
Ash Law,
Yes.
and Ned Colonge.
Yes,
Thank you.
the motion passes. I appreciate all the work, all the comments, and
You
Melissa.
didn't call on me, so I'll say yes.
Oh,
I'm so sorry, Melissa.
thanks, Melissa. We're going to take a 10-minute break. We're behind schedule, but it's okay. We'll shorten lunch a little bit and it'll be marvelous. So please get up and stretch if you do nothing else. And we'll see you back promptly at 10 afternoon for Alex's presentation on standardized outcome reporting. Thank you. All right, so our next presentation is on the standardized reporting of newborn screening outcomes, STAR-NBS, presented by Dr. Alex Kemper. You remember that Alex is Division Chief of Primary Care Pediatrics at Nationwide Children's Hospital and Professor of Pediatrics at The Ohio State University College of Medicine, also the Deputy Director of Pediatrics. He also is the lead for the Evidence Review Group. Dr. Kemper?
Thank you very much. I'm also going to make the world's fastest presentation and try to get us back on time. I just wanted to inform everyone about this small ongoing project that we affectionately refer to as STAR-NBS. And this grew out of work that the Evidence Review Group has been doing around evaluations of newborn screening tests. And one of the challenges that we have when we look at publications is that there's just a ton of variation in how data are reported, which creates confusion, makes it really difficult to synthesize data, and there are wide number of areas that often need clarity. So things like the clinical case definition or the target of screening, what the reference standard is, how the test characteristics are assessed. By that, I mean things like sensitivity and specificity or positive predictive value and negative predictive value. Because sometimes it can be unclear how, when samples are submitted that are inadequate, are taken into account when the test characteristics are calculated, what happens with loss to follow-up, or when they're indeterminate diagnostic test results. There's also variation in how non-targeted conditions are reported and how that plays into the test characteristics. So things like carrier status, if there are other non-targeted phenotypes like late onset disease that are identified, or just other conditions, completely different conditions that may or may not be beneficial to identify. It makes the job of synthesizing the data really quite difficult. There are often other areas that need clarity. So the unit of analysis. So we are particularly interested in looking at the newborn as the unit of analysis, but sometimes reports talk about the screening test as the unit of analysis, and that can be complicated if there's more than one screening test done per newborn. As you would expect, there's evolution of the screening algorithm over the course of a study period, and it can be hard to figure out in some reports when you look at the test characteristics, how does it play out with the final screening algorithm versus one that might have been in progress. Sometimes there's components of cost analysis that are reported or not reported, and it can be hard to understand that. And then oftentimes the plans for follow-up are reported differently in terms of what happens after diagnosis or if there's diagnostic uncertainty. So we are interested in coming up with a standardized reporting guideline that journals could use. And something like this already exists. So there's something called the STAR-D, which are reporting guidelines for diagnostic accuracy studies in general. And there are 30 items, and you'll be happy to know I'm not going to read all 30, that cover most of the points needed to fully understand newborn screening. So if reports followed the STAR-D guidelines, a lot of the issues that I talked about would be covered, but there are some aspects that often that we are interested that need clarity that don't fit into the STAR-D reporting guidelines. And so we proposed an extension to the existing reporting guideline, and that includes the clinical case definition, the targeted screening, the reference standard, and those other things that are bold that I talked about before. I'm just going to skip over. So where are we now in this process? So the STAR-D guideline is part of a network of reporting guidelines that are maintained by something called the Equator Group, and it's maintained on their website. And a lot of journals will tell authors to look at the Equator guidelines when they submit studies related to particular topics. So we want to expand the STAR-D to make it relevant for newborn screening. And we have gone to the Equator Mountains, so to speak, and gotten permission to extend the STAR-D. I've spoken to some experts in the newborn screening world, including sending some surveys and that kind of thing. We've gotten preliminary feedback in terms of things that we thought that might be good to add that maybe we do need, and some that we maybe don't need. And we've put it all together. And at this point, we may reach out to those that are doing newborn screening studies just to see how this would play in the kind of reporting that they do. And once we do some pilot testing and are happy with how things are, then we can go back to Equator and ask them to make it an officially recognized thing. And then it's just a matter of going back to the journals and getting them to recognize that this is out there, as well as promoting this within the newborn screening community. It's, I think personally, is a simple, small request for those that are interested in publishing their work that at the end of the day would facilitate better outcomes in terms of being able to understand findings from studies and being able to synthesize across them and ultimately help with the complex decision-making that this body has to make. So
thanks, Dr. Kemper. I wonder if there are any questions or comments from members of the committee. Jeff?
Dr. Braska.
Jeff Rothgar. So Alex, if I understand why this is so important for the committee and an example of how the federal government is trying to support folks who want to nominate conditions, very often in the evidence review process, we'll hear that you've looked at lots of studies, but it's hard to put them together, make much sense of them, and be able to say, this is what the evidence shows. And this is routinely done in the research world now, that there are standards. If you want to do a qualitative study, you follow this. If you want to do a randomized controlled trial, you follow this. And journals will ask you to do that. So in some ways, what you're talking about is a guide for people who want to do newborn screening research that will allow their research then easily be used in the evidence review process that then informs this committee. Did I get that right?
100%. I should have had you do the presentation.
From my standpoint, I'm fully supportive.
Excellent. All right. Well, then I'm going to hurry up and sit down then before somebody can say something different. Anything?
Organizational representatives, comments or questions?
Thank you.
Yeah. Boy, it's hard to let him off without some grief, but. All right. You know, we talked, staff and I talked after the last meeting when we had Dr. Noyes join us from Bangor, Maine, Bangor, Wales, different Bangor, to talk about qualitative data synthesis and people saying we're trying to put that within context. So we've been trying to systematically learn and understand ways in which data on information other than what the committee usually looks at in evidence reviews might be lifted up and valued and be part of decision making for the committee, especially in terms of the lived experience of families with children with the conditions for which screening is being recommended or examined. And so what we decided to do with this hopefully brief presentation is to try to go over or remind you what we've looked at as we're building the information that we think can help us move into that part of net benefit considerations that includes kind of lived experience and additional information from families specifically. So what we've done is put together a slide set that just reminds you of what we've been through and suggests what we'd like to do next. Next slide, please. So in starting, here's the background. Our stakeholders express the need for patients, lived experience to be taken into consideration in our processes. Those expressed by public comments during our meetings are able to be translated into evidence and therefore considered by the committee. So both the committee members and HRSA staff, we agree with our stakeholders and then have identified the speakers that started since May of 2023. Next slide. The first of those was in 2023. We had Beth Tarini from the Children's National Research Institute present on Mind the Gap. This is a project that describes data gaps for the impact of false positives and uncertain prognoses with newborn screening. Beth summarized active NIH funding research projects looking at the impact of false positives and prognosis. And these used mixed methods approach, including qualitative research. And we're looking forward to follow-up results to be presented at a future advisory committee meeting. Next slide. Then in January of this year, Don Bailey and Elizabeth Reynolds from RTI, and Melissa Raspa, all from RTI International, presented on a project, Family Outcomes of Newborn Screening. This project describes previous research and is using it to develop a tool to measure family outcomes of early intervention, recognizing that there are outcomes that we don't traditionally capture or necessarily consider in our decision-making process. These are HRSA funded, this current study to adapt the tool to family outcomes specifically for newborn screening. And the project is continuing to work with families to develop key concepts around issues such as quality of life. Next slide, please. Also in January of 2024, we had a project described the family search for meaning and value in rare genetic diagnoses. Here, Dr. Ackerman from the University of California talked about her project from the program in prenatal and pediatric genomic sequencing, performed 2017 to 2022, looking specifically at the utility of genomic information from families, exploring the ethical and social issues of exome sequencing, and then presenting data collected through clinical observations and in-depth interviews with parents. Next slide, please. And finally, also in January, we had the value of values, expanding assessment of net benefit and harms through social science data. Aaron Goldenberg from Case Western Reserve presented on the project that describes the need for more data from the family perspective on newborn screening in order to expand our notions of benefits and harms for newborns, family, and for society. He provided an example of Screen Plus NBS study in New York. This is a consented pilot newborn screening program, which is gathering key stakeholder opinions to guide ethically sensitive decision-making about newborn screening expansion. Next slide. In May of 2024, we streamed in Jane Noyes, Dr. Jane Noyes, professor in health and social services, research and child health from Bangor University in Wales. She's talking about qualitative evidence synthesis, specifically the grade CIRQUAL approach for assessing confidence in synthesized findings from qualitative studies. She talked about how qualitative research can be brought together and synthesized in an evidence review that could then be used by decision-making groups. She discussed in depth the grade CIRQUAL approach for assessing confidence in qualitative findings. This word confidence is different from the word that we use in the quantitative assessment, which is certainty, but it's the qualitative synonym, the same concept for qualitative research. And then she provided examples of how grade CIRQUAL has been used in developing and influencing evidence-based clinical guidelines. And we just put a link to grade CIRQUAL in the slide. Next slide. So here are the projects that we've tried to systematically bring forward in front of the committee to think about how we could move forward. And this is a very important source of evidence, the Mind the Gap, early intervention and newborn screening, search for meaning and value in rare genetic diagnoses, values of values, looking at net benefits and harms to social science data, and assessing the confidence in evidence synthesis of qualitative studies. Next slide. Oh, and that, sorry, if you go back, if you hit on that QR code, it will take you to the presentation and slide sets that we had summarized. Sorry, now next slide, thanks. So the conclusions that we've made is that there are established methods for translating lived experience into peer-reviewed research. We also believe that research can be synthesized in the evidence review for a condition nominated for the RUSP. And this is an evidence-based and structured systematic way of including the voices of family in an evidence-based decision process. So the next steps that we are planning on is to bring together a panel on the resources available to fund research that includes the lived experience perspective. And I hope at that time also impart to funders why we think this is a critical area of need. Next slide. With that, I'd like to open the floor to discussion by committee members and then org reps and see if there's any additional comments or suggestions from my colleagues on the committee. And that's what happens pre-lunch, right? That pre-prandial drop in glucose levels. All right, turning to our organizational representatives. Bob?
Hi, Robert Ostriano, American Academy of Family Physicians. This has been, and I've been on this, an organizational rep for quite a long time now. And this has been a concern of mine and ours for a long time as we've been looking at things on the RUSP. And I'm just going to summarize briefly how I've crystallized this in my own mind before I kind of make my comment and ask my question. It seems to me that there are three domains that should be considered when we're looking at net harms and benefits. One of them is, I think, what's been gotten a lot of the focus and attention, which is biological disease-specific interventions. And I think that's often been 98% of the decision-making process. I think then between that and the lived experience is the non-disease specific interventions that early detection can assist with. And I mean, I've done some work with MDA a few years ago, and that was our sense, is that maybe the benefits of that, because of the delay in between symptoms and diagnosis of muscular dystrophy is so long, that those benefits were potentially being overlooked. And then there are the lived experiences impacts of screening. So that's kind of how I've put it in my mind, and I want to make sure that middle one doesn't get neglected. Another concern I have is that we've been so, and I don't mean we here, I mean we as a society have been so focused on assigning a higher degree of validity and reality to things that we can measure than things that are harder to put a number on, that we just constantly caution ourselves not to say, well, we're going to look at all these, but the stuff that has the numbers is going to carry, you know, is going to be something that I assign more reality to. And this has been an issue for a long time, and it's, you know, we run into it in the practice of daily primary care all the time, because, you know, we're judged on what we can measure and not what really matters a lot of times. And then my final comment and concern, and really the question is how are we going to gather information about lived experiences from people who are not forthcoming with their lived experiences? I think people who have suffered harm, in their minds at least, from not having their children screened come forward. I think those who have had benefit from having their child screened and being treated come forward. I think it's harder to find the folks that where the opposite is true, that have benefited from not being screened, or been harmed because of the result of being screened or having a diagnosis. And that has come up a fair amount. In fact, that's been given a lot of weight in some of these early discussions, is, oh my goodness, a false positive is so horrible, we better not consider a test that isn't perfect. But if we're going to do this lived experience research, how are we going to solicit people that have not benefited from, or potentially benefited from the program, or been harmed by the lack of it? And I think that's going to be a challenge to make sure you get a decent data set that way.
Yeah, I think these were questions that I asked Dr. Noyes when she was here. And she said, you just have to do more research. And there are qualitative researchers who, that's what they do. They figure out recruitment methods, survey strategies, and other approaches. But you're right, it's more difficult than, it'd be more difficult than measuring numbers. People who do qualitative research, who have to look through the narrative, develop themes. Dr. Noyes gave an example that two different evidence synthesis groups can look at the same body of evidence and come up with a different set of themes from the same evidence. So it has the challenges that we see in the quantitative research world as well, and things that I'm excited about the progress that folks are making in qualitative data research. The other thing I'm interested in looking at is that there's a recognition that AI and ML and machine learning might give us additional tools that might be a source of greater consistency and extraction of themes and kind of qualitative data synthesis moving forward. I think it may be a little bit before, well, I don't want to predict. AI has moved pretty fast. It's not always moved in positive directions, but the fact that people are thinking about it for data extraction and synthesis from qualitative data synthesis, I think is pretty exciting. So I think those are good admonitions. And I think we're really trying to look for a way that lived experience can enter the evidence stream that leads to the consideration by this committee and those in the future about making decisions about adding conditions to the RUSP. Oh, Natasha, I'm sorry.
Can I have a
Oh, Ash.
very briefly? I would second the comments from Robert that the one place where I have difficulty in assessing and making judgments is the impact of false positives, and I don't think we have some presentations that we've had in the past or some comments we've had in the past, I often feel they are from a previous generation of testing and the impact of how we use genetics now or genetic diagnosis and how that has impacted the general thought process of how people receive news about the genetic diagnosis compared to where we stood maybe 20 or 30 years ago, or potential impact of a genetic diagnosis, which may not be immediate versus later, or maybe some uncertainty associated with the diagnosis, or the pathogenicity of the change. So these I have felt sometimes that there's a lack of current impact of uncertainty or false positives on the families, and how that could be addressed. I don't know whether it could just be a survey during the evidence review group, or it may perhaps be an invitation, invited presentations. Thank you.
Thanks, Ash. Jeff?
Just a quick follow-up that the NIH believe funded, you heard Aaron Goldenberg and the presentation that we had from Beth Tarini, and they just sort of presented that they're going to be addressing that very question. And they should be having results fairly soon. So when they're ready to come back, we're certainly going to have them come and talk to this committee, because you're right, Ash, we need to have updated information on how false positives and other uncertainty really is working in nowadays.
Now, Natasha.
Natasha Bonham, Genetic Alliance. Thank you for the presentation of the recent research in this space. I think it's important to note that, there really is kind of a world of dialogue and discussion amongst patients that does not make it into journals, but it is there. And so really thinking about how to engage directly with those patient groups to hear from them, not necessarily just an assessment or an analysis of some of those experiences. FDA has really great processes around that in terms of engaging families and parents and a whole range of people in the discussion and the actual decision making that they do. So that may be something to look at. And then, and speaking to the point of, how do we get the perspectives of people who tend not to share their perspectives? Oftentimes they are sharing their perspectives. They're just not doing it in the channels that we are tapped into. So even long time ago when we built Baby's First Test, we didn't just listen to patient advocates, but we also went onto discussion boards where people were actually being critical of newborn screening to see what the discussion was there and really dive deep in terms of the questions that needed to be addressed. So again, there are those different both academic and non-academic, formal and non-formal ways to really tap into the varied perspectives, not just a family perspective, but the range of perspectives out there.
Thanks.
Can I just quickly respond to that?
Yes, Carl.
So those are really, really good points. And again, I don't presume to be any kind of expert in this, but I do want to point out that with machine learning and AI, things like sentiment analysis can really be very helpful in being able to make those have an appropriate way to be able to make those assessments and to pull out information as a result of that. So I've been thinking about some of those things. Again, it just as part of my understanding of what AI can do to really help. And it would be really interesting to be able to chat with you about places that you can actually get feedback on where people are talking about newborn screening where we may not be looking. Thanks.
Yeah, I just want to add to that. I think that it is important to be thinking about AI and how that can be helpful, and at the same time hold at the same, equal weight. we've all seen when a new technology comes in that's supposed to solve everything. And then 3 years down the road, people are like, oh my gosh, it has the same biases that everything else has had. So I think that's important to think about. But I mean, yes, every single day there's a new AI technology that can be implemented, that's free, that can be pulled in. So I think we need all of it. It's not a one size fits all. Not that you were saying that, Dr. Cuthbert, but I think we need as many of the resources and thought partners around that.
Yeah, there's a great NIH project called Aim Ahead, which is specifically looking at AI ML in the context of making it appropriate across different marginalized populations, looking at it specifically those issues about how to undo the bias or build supported strategies that are inclusive of other ideas and other concepts, other cultures, and other ways of thinking. So it's a well-identified issue that even NIH is helping us try to sort through. Appreciate the comments. Amy.
Yeah, thank you, Amy Gaviglio, National Society of Genetic Counselors. I have a question and a comment. So my question is the intent of this research to try to obtain lived experiences for each individual disease that is going through a nomination process, or more globally assessing lived experiences of rare disease? So that's my question. And then my statement is as we think about assessment of experiences and potential harms around things like false positive results, I think it will be very important for us to glean the context in which the false positive result occurred. And I ask that, or I've mentioned that in terms of teasing apart whether it truly is the result that causes harm or the way it is communicated and the lack of support provided to families. And I could see that being different if, say, a family meets with a genetic counselor right away. And so I want to make sure that we're not just assuming that a result in and of itself causes harm, but we're really taking the time to understand the context in which that result was conveyed and the support the family gets as part of that process.
Yeah, I think those are great additional comments. And I think as we've thought about it, at least started that it would not necessarily be I mean, the research that's going on now is not topic specific. And the concept is that within some limits, the topic, it should be agnostic to the topic. There may be issues of rarity or severity or treatment availability or other issues that make it different. But I think we're thinking kind of high level summary, at least as we get started. And then thinking about the evidence review group, there's a category of evidence called evidence by analogy. So it worked in this setting. Is there any reason to expect it wouldn't work in this other setting? The issue about how the information is provided, I think, is an important contextual issue. Thanks. Thanks so much for the input. Stay tuned and I'll turn things over to Letitia.
So we're going to head into lunch now. Just as a reminder, there's a cafeteria right across the way here. There's also a store back this way where you can get a hold of snacks if needed. Please let HRSA staff know if you must exit the building. Tina is in the back there. She was waving her hand, but we really encourage folks to stay in the building if possible.
And this slide is incorrect. It should say 1:45.
Yes.
So we're going to give you a full hour for lunch. And this is just a leftover from earlier strategies. So please resume promptly at 1:45 and we'd be exactly on schedule. Thank you. We have been talking and we've even heard references this morning about issues around what state newborn screening systems and programs and labs can do and things that are more challenging in terms of implementing when our intent is to try to look at universal screening for different rare conditions. So there are other approaches that have been used successfully in the past. Things like clinical standard of care as an alternate pathway for achieving near universal screening and clinical care. Also, clinicians and organizations use continuous quality improvement as a way to do this, just like newborn screening programs do, or organizations or HMOs who are competing in the marketplace use HEDIS measures. Sometimes there may be state involvement that's neither appropriate or at least not easily done, especially for things like point of care screening. So we wanted to have a more in-depth look at how this is achieved outside of the state newborn screening systems and state public health, and have brought kind of two folks to present today. We're going to have, first, we're going to hear from Dr. Stephen Patrick. Dr. Patrick is professor and chair of the Department of Health Policy and Management at the Rollins School of Public Health. He's also the co-director of the Center for Health Services Research and a practicing neonatologist at Emory University. He's an adjunct physician policy researcher at RAND Corporation. Dr. Patrick joined Rollins from Vanderbilt University Medical Center, where he was professor of pediatrics and health policy. The William Long Director of Child Health Policy at the Vanderbilt Center for Child Health and Policy, and the Executive Director of Firefly. I also am going to ask to come back to the podium Dr. Alex Kemper, Division Chief of Primary Care Pediatrics at Nationwide Children's Hospital and Professor of Pediatrics at The Ohio State University College of Medicine. His research focuses on preventive services in the primary care practice setting. He has partnered with the American Academy of Pediatrics in activities related to Bright Futures and the periodicity schedule, which is the evidence-informed age-based recommendations for preventive services. Dr. Kemper also did as many years as they would let him as a member of the U.S. Preventive Services Task Force, which is another evidence-based group that makes recommendations that can be covered with first dollar coverage under the the ACA Act. So with those introductions, is it Dr. Patrick starting, kicking off? I want to welcome you, Dr. Patrick. We see you on screen, and we're going to let you go first.
Wonderful. It's great to see you all. Do you see my slides?
We do.
Fantastic. Well, it's great to be with you all virtually. I am also a practicing neonatologist. And so part of what I was asked to do today is just talk through some of the critical things that happen during the beginning parts of life and give a couple examples of things that we do for newborns, particularly preterm newborns in those first few critical minutes and hours, and talk about the care processes, some specific actions, and how we work to make them better. So our objectives today for my brief time is to discuss these critical transitions in the first hour of life for extremely low birth weight infants, describe temperature control as an example of care process improvement early on in life, discuss some risks for opioid-exposed infants, and how process improvement of discharge transitions can occur for opioid-exposed infants. Again, all focused on improving outcomes. Well, this is a preterm newborn. Extremely low birth weight infants are small and they are vulnerable to many complications early on in life. And this is kind of like what things feel like in the delivery room. And at that moment, multiple steps need to be taken to ensure that newborn does well. Here's just an example of admission order sets, just taking a picture of what happens for a extremely low birth weight infant around the time of birth. And just to give a sense of this, there's more than 30 standard admission orders listed here. And certainly you can go through multiple decision trees of the things that need to happen, from everything from glucose monitoring to blood test monitoring to processes that need to occur. But if untreated, extremely low birth weight infants, these are infants less than 1 kilogram, will develop respiratory failure, hypothermia, and hypoglycemia. And so this golden hour in the first hour of birth is really an optimal time to prevent these complications and avoid both morbidity and mortality. One of the things I wanted to focus on is temperature, because we often say, measuring temperature seems like an easy thing to do. If I said to you, gosh, we should just measure temperature in newborns when they're born, you would say, well, of course we should be doing that. That seems like an obvious thing. But what we've discovered in hospitals across the US is that oftentimes we fail to do that, or we fail to set the circumstances up to where infants have normal temperature. We know that hypothermia is less than 36.5 degrees Celsius. 37 degrees is 98.6 for those of us who work in both a metric and non-metric world. Newborn temperature can drop 2 to 4 degrees Celsius in the first 30 minutes of life without interventions. And that's for a couple of reasons. One is body surface area to body mass. Infants have a ton, particularly preterm infants, have a ton of skin and not a lot of body mass. Imagine any one of us walking around right now with twice as much skin as we have. You're going to lose a lot of heat. Subcutaneous fat, they have less of that than we all do. And immature vasomotor control, the sort of ability to sort of open up vessels to control temperatures a bit better. In one study, every 1 degree Celsius decrease in admission temperature was associated with a 28% increase in mortality. This is true in the US, and certainly there are multiple studies outside the US that associate hypothermia with poor outcomes. We often think about the ways infants lose temperature. These are kind of the 4 big ways. There are things we all think about, but when applied to a newborn, you can see how things come together. Radiation, they just lose heat. This is why we think about hats on infants. Convection, wind coming by and kind of taking just like a convection oven. Evaporation, infants are wet when they're born, so they lose temperature. And then conduction, if you put them on a cold surface, they will lose temperature that way. So what can we do? I mean, some of these interventions are pretty darn simple. Put a hat on the baby, blankets, skin-to-skin care with the birthing parents, increase temperature in the delivery room or operating room, a radiant warmer above the infant, a chemical heat mattress underneath the infant, particularly for very preterm infants, and a polyethylene bag, if you can believe that too. It literally looks like a Ziploc bag. Even with these simple solutions, a 2016 analysis found that nearly 2 in 5 very low birth weight infants were cold. And this is an analysis from the Vermont Oxford Network, which includes data from about 80% of hospitals that care for these types of infants. Here's an example of a bag that an infant is placed in. Sorry for the low quality image, but you get a sense of like, yes, in the delivery room, just placing an infant in a bag like this can be effective. So I wanted to share an example of one hospital. This is published in the Journal of Hospital Pediatrics a couple of years ago, how they approached improving what isn't a very important problem that seems like we should be able to address that pretty easily, right? So they went through and developed a driver diagram, and I know Dr. Kemper is going to talk a little bit more about these types of quality improvement efforts. Where are they starting? What's their aim to decrease the rate of hypothermia? Pretty straightforward. What are the primary drivers? We can go down the line of staff knowledge. Do the staff know about evidence-based control? Have they heard about the evidence-based protocol? Have they heard about the protocol? And then what are the interventions? Working backwards to that. Expansion of chemical heat mattress, bedside laminated cards, guideline badge cards. Like every hospital has a unique approach. And this sort of broader approach to quality improvement works through Plan, Do, Study, Act. And so you plan an intervention, you do it, you study to see how it was effective, and then you modify. So if your initial intervention, let's say your first intervention is like, okay, we'll try a hat. If that doesn't fix the problem, then you modify the intervention until you get to where you need to be. It's different than a clinical study like that. So here's their results. When they started in January 2016, only about 40% of infants were below the desired temperature. And you can see as they go through cycles, and these cycles are these PDSA cycles, where they've done audits, then they expanded heat mattresses, and then kind of modified things further. And so you start to see this improvement, including sustained improvement, and just doing the right things that we know improves outcomes. This is part of how process can improve. And we can pull out processes for many things, including glucose control, which is a diagnostic test we do pretty early on in life. I wanted to talk about just another one that's from our group where at Vanderbilt, where I was before. We know that nationwide, about every 15 minutes, an infant is born having opioid withdrawal in the US, and opioid-exposed infants are at risk for adverse discharge complications, including readmission. Many infants that are opioid exposed are not connected to critical post-discharge services. And this is important. One of those services is ensuring they've been tested for hepatitis C. In our setting, about 40% of opioid exposed infants are also diagnosed with hepatitis, or also exposed to hepatitis C. But you can't test newborns during the birth hospitalization. It's completely silent. You have to wait until they're a couple of months old. Because of that, less than 20% are tested to see if they also develop hepatitis C. That's not just unique to Tennessee. That's true in other areas of the country, including some work from colleagues in Philadelphia. So we came up with a pretty simple checklist. We should schedule a pediatrician visit before discharge, referral to home visitation services, referral to early intervention services to provide developmental support, referral to our development clinic, and if exposed, referred to hepatitis C follow-up. Here again, you'll see the kind of similar discharge, key driver diagram where we sort of work through where we want to be. We believe in kind of SMART aims, right? So being really specific, increase successful completion of the discharge checklists from 2.6 to 40% by January 5th. And you can see how we work through those problems. Similar to us, when we looked back to see, okay, how often were we meeting those things within the checklist every time, we were pretty poor. And we were essentially zero. And then some simple interventions, beginning a bundle, a measurement of the bundle, just measuring it brought awareness to that. Doing some resident education and sticky notes in the electronic health record, improve things further. And then doing some bi-weekly resident reminders. You can see this dip. This dip was when we had lost a social worker. But you can get a sense of, as you begin to improve processes, you can start to do things that are complex. So improving care processes can be exceptionally effective. And there are a lot of key resources. I mentioned the Vermont-Oxford network before that captures around 80% of very low birth weight infants, but they also do quality improvement around term infants. State perinatal collaboratives are funded by the Centers for Disease Control and Prevention, Division of Reproductive Health, coordinated by NICHQ, and often have a state partner like in Tennessee, Medicaid, and then certainly guidelines. I mean, I'll point out to some of the ones that we've worked on, and the opioid withdrawal syndrome that also has elements of a checklist. So, my goal for this was just to introduce what quality improvement processes can be for newborns. I realize that we're looking at this through the lens of newborn screening and things that have to be there. So I think we'll have an interesting discussion and look forward to that as we move forward. Here's my contact information.
Thanks, Dr. Patrick. And now Dr. Kemper.
So thank you very much. And thank you, Dr. Patrick, for teeing things up. We're going to switch from the NICU and talk about things that happen after discharge from the newborn nursery. This is something I feel very passionate about. I'm really excited for this opportunity to talk about approaches to screening in childhood over the next 6 hours, right? Is that how long I have? That's because I could do it. So I just beginning with a disclaimer that these reflect my thoughts, not the American Academy of Pediatrics, the evidence review group. We're not going to be talking about newborn screening or really any other organization. To help sort of pull things in, I did come up with a series of learning objectives that we're going to do actually within the next 20 minutes or so. So I'm going to summarize general prevention strategies and how they apply to primary care pediatrics, to construct approaches for primary care prevention. At the end, you should be able to relate approaches in primary care to newborn screening, right? So where's the analogy? To evaluate approaches to primary care prevention, to explain the importance of processes and outcome measures. Dr. Patrick talked a little bit about those, and then to navigate the process from recommendation to implementation. And those questions came up earlier this morning. So it'll be nice to return to that. I like to think about different levels of prevention because it ties to the kinds of things that we can do to improve health outcomes. So you'll hear me talk about primordial prevention. Sometimes these are avoiding the risk factors early in life that can lead to disease. primary prevention, which is avoiding the condition by elimination of the disease agent or increasing resistance. Secondary prevention, which is a lot of the work that we do in this group, which is addressing the condition early before symptoms, and then tertiary prevention, which can include things to reduce the harm of the condition in the first place. And if you think about prevention across these different levels, you can come up with different interventions that you could put into play. So as I talk about preventive services, I want to be clear that we're talking about delivering services to individuals who are asymptomatic or who aren't recognized to have the condition. And there are a range of things that we do in primary care. We counsel, we give preventive medications, and we screen. So oftentimes in this room, we focus on screening, but it's important to remember that there are these other components of prevention as well. I do also want to distinguish between screening and surveillance. And when I talk about surveillance, I'm talking about surveillance from a clinical perspective, not a public health perspective. So screening is case detection at a single point in time. So, you know, there's a newborn and I'm going to test them for PKU. Surveillance, again, from a clinical perspective, is an individual ongoing longitudinal evaluation. So, for example, at the individual level, we get to know the child over time and can see how well they're doing in terms of meeting their normal developmental trajectories. Again, surveillance in this way is different than using data for public health practice, which is the sort of public health term. But again, this is a clinical talk, and I just want to throw that term out there. There are lots of places where recommendations for what happens in primary care pediatrics come from. So there's the EPSDD benefit, or the early and periodic screening, diagnostic, and treatment benefit. These are requirements for Medicaid enrolled children. There's the advisory committee on immunization practices that makes recommendations for the immunization schedule. This one, I think most of you have heard of it, the Advisory Committee on Heritable Disorders in Newborns and Children. There's Bright Futures, which is a cooperative agreement between HRSA and the American Academy of Pediatrics. I'm going to dig into this a little bit before. Dr. Kalanj mentioned the U.S. Preventive Services Task Force recommendations that come forth from them that are A and B recommendations are covered first dollar through the Affordable Care Act, but so are things that are in Bright Futures. There's some caveats that are complicated, but you can think of it as leading to coverage. And then there's the community guide, which makes recommendations around community level preventive services. So I mentioned before, Bright Futures is this cooperative agreement between the Maternal and Child Health Bureau and the American Academy of Pediatrics. It's an evidence-informed series of recommendations. It really comes in two different components. There's the periodicity schedule, which I'm going to show you in a second, which is the list of expected preventive services that happens at each routine well child check. And then there's a book, which is very thick, that goes over how to implement comprehensive well child care. It's the periodicity schedule that carries the weight of the Affordable Care Act. So I put this up just to show you. I don't expect anybody to read anything. You couldn't even if you wanted to, but shows all the different preventive services that are included in the periodicity schedule. So if you look at the columns, those are the individual well child visits from infancy to early childhood to middle childhood to adolescence. And then if you look across in the rows, those are the general preventive service categories, which include history, measurement, screening, development, and so forth. Wherever you see a dot, which hopefully you can see a whole sea of dots, those are where the expectation is that preventive service will be delivered at that particular visit. In contrast, there's the book, which is like a huge tome that describes the 32 age-specific visits that are recommended. And the book itself really boils down to focusing on caregiver concerns, childhood development, and positive reinforcement for families. Across the various visits are themes. I'm not going to read through each theme, but you can see how this really hits all the things that are important for child development and overall wellness. The Bright Futures recommendations also outlines a visit structure which focuses on understanding parent and child concerns, surveillance and screening, assessment of strengths, and then various age-based visit priorities as the child and teen ages. Obviously, the priorities for each visit changes a little bit. So as I talk about through things, I always try to keep a life course perspective. And so the things that we're going to focus on ultimately, we're moving towards a healthy trajectory. And as a child ages, there's things that we can do to promote the healthy trajectory. So focusing on things like emotional health, literacy, reading, and so forth, while at the same time avoiding those things that can decrease the trajectory, including poverty, poor access to care, toxic stress, and so forth. As part of the work that we do as primary care pediatricians, is focusing very much on the social determinants of health. These are the conditions in the environments where people are born, live, learn, work, play, worship, and age that affect the wide range of health outcomes. These can be broken into domains of economic stability, education access and quality, healthcare access and quality, neighborhood and the built environment, and the social and community context. Everyone, I hope, hears a lot about social determinants of health. I actually tell you, I do not like the term social determinants of health, because if you call it a determinant, then you're sort of implying that an individual who's been exposed to these things is doomed. And so I really try to use social drivers of health, and that there are things that we can do to affect these things. I think I am now out of, well, it still looks good over there. So I'm going to pretend like my screen didn't change. I am, in the interest of time, going to skip through some stuff on the U.S. Preventive Services Task Force, other than to say that it makes evidence-based recommendations. And I think everyone has seen the grades that it comes up with before. A's and B's are things you ought to do. D's are the things you shouldn't do. I refer to them as don't do. The C's are the things that maybe have a benefit, and you want to talk to families and see if this is something that they want. So I think of C as standing for have a conversation, and the I's are where the evidence is insufficient, and you have to look towards other things to make recommendations. So with that as background, I just want to tease out some stuff that I see as different between newborn screening and what happens in well child care. So newborn screening obviously happens in the newborn period, so it's only early in infancy. It's basically once or twice if you're in a 2-screen state, and then you're done. There's near universal access to screening. Families don't really have much of an option about newborn screening. I guess the only option is whether to be screened or not to be screened, but it essentially happens. And then there's this strong public health involvement through at least diagnostic confirmation, and in some cases a little bit longer, but at least there is this important role that the public health plays. As opposed to well child care, right? That happens at any age. It's repeated. It can be informed by surveillance and other personal factors, including concerns that might come up from the family. It's certainly not universal, right? So we know that there's issues related to access and variations in quality. There is an opportunity for shared decision-making, right? So you can't really have like a USPSTF-C category and talk to families about whether or not they want to be screened for something as part of newborn screening. But as part of this kind of thing, you can, right? And then generally, as part of well child care, there's no public health involvement. There's some exceptions, things like lead screening and that kind of thing, but generally not. So I think a lot about the importance of well child care to address disparities. And again, we could talk for a long time about disparities, and I know that that's not the focus here, but I do think it's important to bring up. So this is a slide of infant mortality in Ohio over 10-year period of time. And it shows the difference between Black infant mortality and white infant mortality at the bottom. And then you can see the average Ohio infant mortality rate over time in the dark Black line. And in all of our work, in all of our quality improvement work, we break things up by race and ethnicity to make sure that we're, first of all, not causing disparities and that we're addressing the root causes of those disparities that exist. Because, on one hand, if you just looked at sort of like relative improvement, right? So there was this improvement over time in the Black infant mortality rate in Ohio and in the white infant mortality rate in Ohio. But that's a huge difference, right? This is something that we should be all upset and invested in. And as I go through and talk about some particular activities, I just want you to keep this in mind. The root causes for these disparities are complicated. Again, I'm happy to talk about it, but it's hard to think about any aspect of healthcare delivery or health outcomes where you don't find these kinds of disparities. The other thing that I think about is, and we're going to drill into the work that we do within our primary care network, is the causes of death and when they occur. I show this slide not to pit one group against another group in terms of what's important and what's not important, but just to provide context. So, in the early ages, birth defects around 3 per 100,000. This is in ages 1 through 4. But then if you look at it in the older groups, it's things like unintentional injuries and suicide that really dominate the causes of mortality in the United States. In the United States right now, for children and adolescents 1 and older, the leading cause of death is related to firearm injuries. So again, we think a lot about what's causing harm to the patients and families that are in our responsibility. And that's led to something that I received that we refer to as the Vital Signs Project. This is a list of the targeted preventive service activities that the network that I'm going to describe in a second focuses on. We already talked about infant mortality. Kindergarten readiness is another one. High school graduation. The Preventive Care Index is just a summation of generally recommended preventive care, things like vaccinations and those kinds of things. Teen pregnancy, obesity, all-child mortality, and suicide. So as I show you a little bit about who we are as a network, know that these are the things that we're really focusing on, but we're also holding ourselves to improve these outcomes for everybody who lives in Franklin County, regardless of whether or not they come to us for care. We have an approach to quality improvement that's based on standard quality improvement activities with small tests of change and looking to see at the difference it makes. This is who our network is. We have 14 clinics around Columbus. We have over 130,000 unique patients that we provide care for, with about 240,000 patient visits annually. Nearly all of our patients are Medicaid enrolled and part of our accountable care organization known as Partners for Kids. So here's some examples of things that we've done with quality improvement. At any given time, we have about 30 different quality improvement projects ongoing. So we look a lot at access, right? So we're not going to be able to deliver preventive care services if we don't get patients in. So this shows our patients with 6 or more well child visits by 15 months of age. And you can see that went from about 45% to about 60% over time. These are our patients with 2 or more visits between 15 and 30 months. And you can see that that's hanging out now around 60% as well. And then we look through the teen years, and you can see that we try to label these things as we try different activities to get people in. So I say this, I show these slides just to highlight the importance of thinking about access and getting patients in if you want to be able to deliver the preventive care services. We follow things like immunizations. You can see how we're doing on time over there. Here's the adolescent immunization schedule over time. We drill into specific services like HPV vaccination. Here's our work around depression screening for children 12 to 17 years old coming in for well child care. And you can see how critically important it is to follow how things are going on over time. Boy, April 2020, what happened then? I'm trying to block that one out. All right. And then it's not enough just to look at how we're doing with screening, but we also look at the patients who had a positive screen and whether or not they got recommended therapy. Again, you can see how that's changed over time. I show this, I could have pulled this up really for anything that we look at. This is our suicide screening activities broken down by race and ethnicity. It's sort of a messy little spaghetti diagram, but we do this for all of our work just to make sure that we're recognizing disparities and developing interventions as appropriate. Here's an example of interventions that we had to do in terms of increasing our use of interpreters to ensure that there wasn't a disparity in developmental screening by preferred language. There are dozens of languages spoken by our patients. I show this just to point out that all this stuff requires ongoing measurement and practice, redesign. This is a slide showing our access to care. And what I would say is that if we really want children to get the preventive care services that we want, there are things that need to happen related to the recommendations that need to be clear and comprehensive. There needs to be a burning platform. Somebody needs to care about it and measure it. You need to have process measures that you can look at over time. There needs to be quality collaboratives with participation. You need to collect data in real time at the practice and the clinician level. There's nothing better than being able to go back to a clinic that's having problems and show how they compare to their peers. As an aside, we do something that we refer to as March Metric Madness, where we pit all of our practices against each other during the NCAA tournament with a big trophy that gets awarded at the end. Again, informatics tools, population focus, and aligned incentives. I didn't mention this before, but most of those slides that I showed you of the control chart showing how things were done over time, the denominator is not who's coming in for care. It's who's assigned to us. So it's really important to think about things from a population standpoint, right? If somebody's not getting a preventive service because they're not coming in, we need to be responsible for that and come and figure out why they're not coming in. As a matter of fact, we have things like Lyft services to bring patients in to get them. And we've developed a school-based health program so that we can get patients that aren't coming into the clinic. So that was a whirlwind tour. Obviously could have talked about things a lot more. I just wanted to put up the learning objectives just so that you can remember what we just went through. And what was funny is last night as I was going through the slides and looking at things again, I don't know how this happened, but look at that. Okay, I don't want to tell you how many hours I spent on that. And just in case you're wondering, I did not use ChatGPT. Right, this was all me. This was all me. So I guess I'll just leave it right there. But I think that there's really tremendous opportunity to for recommendations that come forth from this committee to help inform what happens as part of well child care for things that maybe don't fit necessarily with newborn screening. And I would say that while the preventive care services that happen within primary care are not perfect, they can be really good, especially when you can tie together this larger population perspective.
Alex, are you willing to stand up there while you and Dr. Patrick answer questions?
I would be honored.
Let me start with one intervention that that just because I've been involved in it a lot, I know well. It's a birth dose for hepatitis B. So Colorado uses hospitals to deliver the birth dose for hepatitis B. We're well over, I think, 98% success rates in hospitals. As soon as we get to birthing centers and home deliveries, it drops off quite rapidly. But are there other examples of that kind of and Dr. Patrick, you as well, you've talked a little bit about hospital delivered standard of care interventions that you know about that we've been successful in getting high participation rates that don't look differential by identities.
Yeah, I can talk about one example. And then Stephen, I was going to talk about bilirubin. If you have like another example. So newborns are at risk for complicated reasons of having high levels of bilirubin. And for some of them, if you don't treat them, it can lead to a problem called kernicterus, which is a form of brain damage. The current, I was actually the lead author on the new AAP bilirubin guidelines. So I feel like I had to put that out there for whatever it's worth. But the recommendations are for all babies to have bilirubin levels checked before they are discharged from the newborn nursery or go home. And then based on the bilirubin levels, they either need treatment or need to have, a lot of them need to have close follow-up with primary care for follow-up bilirubin levels. The American Academy of Pediatrics just led a gigantic quality improvement activity to confirm that the babies are getting bilirubin testing prior to discharge and that they're getting the appropriate follow-up, including with primary care, based on that bilirubin level. And it was really a smashing success. Now, there were opportunities for improvement in ensuring that the children got, there's actually a bigger problem with overtreatment than undertreatment. Based on bilirubin levels. But I think that's an example of like a big win that this committee could look at.
Dr. Patrick?
Yeah, there are lots of examples, actually. I mean, like everything from vitamin K to antibiotic ointment at the time of birth to congenital heart disease screening with a pulse ox prior to discharge and everything in between. There are a lot of standardized processes that occur that, if you just go around and look at an average state perinatal collaborative and the work that gets done, sometimes complex, sometimes not, definitely. I mean, another example would be, changes that we've seen around, around kind of promotion of breast milk in hospitals. Like there are lots of examples of just what you're talking about, kind of creating processes to make sure we get that first hepatitis B vaccine prior to discharge. We're seeing the same thing around RSV prophylaxis with some complexity right now and who gets it and who doesn't. But we can implement things within hospital settings and do them very quickly and modify them. The congenital heart disease screening is a great example of that, where we do a pulse ox screen universally for infants that might be at risk of having congenital heart disease that may not be apparent. These things was not something we did 30 years ago. These are processes that occurred over time.
Yeah, and I often bring up I did this morning, the congenital heart disease screening is a RUS measure, but it's a RUS measure that state newborn screening programs and labs have little implementation strategies for. I think in Colorado, there's just a checkbox that says, yeah, we did it. And that's what the state does. And so implementing point of service tests are things that where hospitals and birthing centers can be very important in terms of the rollout and the strategy. Melissa?
Melissa Parisi, NIH. So thank you both for those presentations. A really great reminder of some of the challenges and differences and opportunities for not only newborns, but childhood screening and identification. And I do want to say, Alex, that having just recently taken my maintenance of certification exam and having to review the 40-page document on screening for hyperbilirubinemia, in advance of that, I'm grateful that you did it. It is extremely long and detailed, but it is exactly what the field needs. So
The check is in the mail. So I will tell you that I got the MOC bilirubin question. I was so nervous I was going to get it wrong.
Yeah, I had that question last month too, that series of questions, and I don't have positive feelings towards Alex. I'm just kidding.
I had a little bit of sarcasm in my voice in that, but all seriousness, all joking aside, I should say, I did have kind of a question and comment for you, Alex, when you showed your graphs of how you had achieved some of your goals of 60% or approximately 60% of your population actually meeting those targets for coming to clinic and being seen for well child evaluations. There were a couple of things there that like little arrows saying this is the intervention that caused those things to go up. And one of them was EPIC notifications, and one was also opening a clinic in a high opportunity area. And I just wondered if you could say a little bit more about those interventions and what they consisted of and how effective they were.
Yeah, so let me take the second thing first. So I have a heat map of all the patients that are attributed to us. And I also know where populations are that aren't coming in. And we use that to drive where we open our new clinics. And we also use that to drive how our clinics are set up. So we have a hub and spoke model where we've divided the city up into 5 quadrants. And in each of the quadrants, there's one clinic that's bigger, and we bring services into there that we know that families are not accessing that they would benefit from. So for example, dental services, speech and language services, those kinds of things. We're also bringing in a psychiatrist into the hubs as well. I didn't mention before, I'm very proud of this. We have a psychologist in all of our clinics. I can tell you how the secret later about how we were able to do that. So we use real-time data to drive all of our clinical operations. EPIC is we use our electronic medical record judiciously for sending messages and engaging families, because we know that if we put too many alerts in there, people get alert fatigue and they completely ignore them. The other thing that we're doing now is we have a text system for families to deliver messages about when they're due for things and that kind of thing. So we try to leverage the electronic medical record in a way that's actually useful and not overwhelming for people.
Ash?
Perhaps a 2-part question. The first is just for information. when we talk about differences in infant mortality, and looking at Dr. Patrick's presentation before that, I was just wondering what component of the infant mortality differences could be explained by the perinatal events, and what are due to things that happen after the first 28 days or.
Yeah, so we, but let me talk to you about what we do first, and then I think Dr. Patrick can probably give a sort of a broader perspective on things. So like most communities, we have a child fatality task review, and we look at each infant death to identify the root causes. So although there's no question that things like prematurity lead to some of these deaths, a lot of these deaths, the lion's share of them, were potentially preventable. So things like co-sleeping and those sorts of things that in retrospect, interventions could have been done to prevent those deaths. So I'm very careful. I mean, there's no question that prematurity and other early events like that it's too late for us as pediatricians to necessarily prevent lead to some of these deaths. You can't pin most of them on that, certainly not in our community.
Well, I'm happy to sort of to dive into this just briefly. If you look at maternal deaths, maternal mortality, and you look at infant deaths, you see a lot of themes. And those themes that you see are huge disparities. We see the same huge disparities in maternal deaths too. Black moms are about 3 to 4 times as likely to die as white moms. Those same issues of equity are there for American Indian, Alaska Native populations too. So I view this as dyadic care, that it's our responsibility to care for mom and baby. Because, we see, like, let's use the opioid crisis or substance use as an example. Treatment for substance use overdose is a leading cause of pregnancy associated death. And in states like Georgia, Tennessee, Ohio, it is the leading cause. So I tend to approach this from healthy moms have healthy babies. And, it's true that the 3 leading causes of death for infants is prematurity, birth defects, and sleep-related deaths. But those broader issues of equity and systemic racism, I think, drive through the through force of all of this. So when we can look at this holistically and think about what do we do to begin to address the prematurity rate by looking upstream from a public health perspective, like the primary, secondary, tertiary approach that Alex pointed to earlier, I think that's important as we think about this. So for example, we know that treatment of substance use in pregnancy reduces risk of preterm birth. Preterm birth is associated with mortality. Like that view of maternal and infant mortality, I think is really important. And what we see happening are parallel conversations often, where we see a focus on the unacceptable maternal mortality rate that's happening in the US. That's around 900 deaths. And we see separately a focus on the infant mortality, and those are around 25,000 deaths. I think we're better off if we look at them together because the through point in terms of, I like the social drivers of health, are more similar that way. And the interventions, while some are clinical, more broadly, there's a lot of things that happen outside that I think are pretty important. I hope that answered your question. It was not too much of a broad view of maternal and infant mortality.
Thank you. My second question to Dr. Kemper is I think high risk infants require both primary care as well as specialty care. And I just wonder from your experience if you think that has it been relatively simple to organize and coordinate care between the specialty center and the primary care physician, or are there things that you think need to be improved in the communication coordination of care?
Yeah, so if I understand your question right, it was about, sort of coordinating things between the primary care pediatric side of things, the OB, the internal medicine side of things that are taking care of the families as well, or?
No, this is postnatal. This is between the specialty
between the
pediatric
specialists?
specialties and the primary care pediatric.
Yeah. So we found, the interventions that we found that have made the biggest difference are really primary care based interventions. I mean, I'm lucky to be right in a quaternary academic center where we have pretty good access to the, the sub specialists. But one of the key things I hope everyone gets out of this is that the differences that we've been able to make in child health outcomes have really been built within primary care. I mean, to go back, I just feel like I want to build on the comments that Dr. Patrick made about focusing on maternal and child health as well. So our city has a program called Celebrate One, which is focused on getting children through to their first birthday, so celebrating the first birthday. And there are a ton of interventions that we have going on both within primary care as well as outside of primary care within the community to help ensure that the children are healthy when they get to 1 year of age. So it's true that we definitely need our subspecialty colleagues, but it's actually it's pretty straightforward for us to get in with them as we need them. But and I hope this is, if my subspecialty colleagues are listening, Margie over there who's like a huge help, right, in neurology. But most of the improvements that we've been made have been made by focusing on what we can do within primary care.
Honestly, I think all of it's from neonatology. I'm just kidding. I would also just like to put a pin on that. Like in our system, the system I was previously part of, that's subspecialty care. So let's take hepatitis C. Infants exposed to hepatitis C got a referral to the pediatric liver clinic. Like talk about super specialized. You go like GI and then liver to test for hepatitis C exposure. Well, that certainly doesn't need to be a tertiary care piece. So like, and as we work to support through some of our programs at Vanderbilt, one of the things we built out was how do we support primary care? How do we provide the support to our rural communities to not just do things like test hepatitis C, which is lost, but also to be a resource when you see, we might see a ton of opioid exposed infants, but that rural practice may see 3 a year. So how can we help support that? I think that's part of developing a sustainable model, particularly as we are looking towards a future in pediatrics where we're starting to lose subspecialties and there's substantial concern about what our workforce is going to look like in the future. We're going to have to think about things differently.
And again, just to build on that too, because you sparked another thought, which is we need to reward pediatricians based on the quality of care that they provide, not the volume of care that they provide, right? So, we have, many people like rely on their RVUs. I know Dr. Ostrander's like, I think he rolled his eyes a little bit when I said that, but that's what we do,
So, one of the reasons I really focus on the hospital setting is, it's kind of like, why do we do newborn screening tests in the hospital? It's Willie Sutton. It's where they're born. It's a universal, almost, how about the vast majority of children go through the hospital in terms of beginning life. And so I always think of those hospital interventions. My question, so I talked about a success. I'd like to get your ideas about areas where we haven't done so well in terms of the practice of pediatrics outside of the hospital setting. So I think everyone knows what EPSDT is. And in that set, which is a Medicaid program, there's payment for universal lead level testing. I'm in public health. I believe in lead level testing. And when we look, at least in Colorado, at our success rate in Medicaid patients for whom clinicians are already being paid to do the test, our first year success rate is under 50%. And our second year test, putting them together, is under 22%. So what are the levers that you think we can push outside of the hospital to think about screening? Because somebody said it earlier, we're the advisory committee for heritable disorders of newborn and children. What kind of strategies, other than EPIC or some of which most of these clinicians have, do you suggest, or are there ways we can address to get screening for other heritable disorders outside of just the newborn setting in the hospital and more broadly into the pediatric care community?
Well,
while you're standing.
I mean, I'm going to lead by saying that our lead testing rates, both at 1 and 2 years of age, are in excess of 95%. So, well, I mean, it's true, and that's at a population level. So, I would go back to the slide that I had before, that you need to have a clear and unambiguous recommendation. There needs to be a burning platform. There needs to be a quality improvement collaborative to get it be done. Somebody needs to be on the hook. There needs to be responsibility for ensuring that this happens. You need close to real-time data, and that people are underperforming, then that needs to be made clear. We also had, again, this was like a whole nother, I could talk for hours about this, so I apologize to everyone, but we found that our most successful interventions to also engage people from the community to help us think about practice redesign, because we sort of get blinded to what needs to be done. But I mean, I think all this stuff is doable. We just need to have all the incentives aligned and the expectations.
Yeah.
So I'll be a little more pessimistic, if that's all right. Like the reason why I think we have systems where the incentives aren't aligned, and in maternal child health in particular, we have fragmented systems that exist in health and human services that are often siloed. We don't have a whole child view. Like, yes, we have that in communities, we have it here. But if I go to, North Georgia, I go over to if we're thinking about creating equitable systems that are across the entire US, then we have to think about how the systems are put together. We have a challenge with generally lower Medicaid reimbursement in many communities. Medicaid is one place, though, that where many states have multiple different Medicaid managed care organizations who may have part of the state. How well does that group work with everything from the foster care system to early intervention services to, in my experience, those are usually pretty siloed. And then, Dr. Kemper mentioned data systems. Well, most state data systems are also siloed. What you may have Medicaid data here, you have IDA Part C data here. Those systems don't talk. And if you wait to get those data systems federally, they're multiple years old. So in maternal child health, I think we have to find a place where we can begin to align incentives that are focused on holistic child care, that include the things that matter as we're thinking about social determinants or drivers of health, where we can, create incentives and Medicaid that incentivize human services outcomes like decreasing foster care and vice versa. I think that's what the future needs to look like. And it's worth saying, if we compare children and newborns to seniors, one of the differences is the way systems are structured. We have one Medicare program, we have more than 50 Medicaid programs, and many of the systems that serve the patients we serve are a mix of entitlements and block grants that are administered everywhere from federal, state, and local. And I think that's part of the confusion and part of the siloing that we see.
Yeah, I think just to piggyback on that too, certainly there issues with Medicaid and lack of Medicare parity and those kinds of things, but private insurance has a lot of problems. For example, we have, patients with high deductible insurance plans, and even though they get a lot of the preventive care services covered first dollar, it's sort of all the add-on stuff that happens downstream. And so families get concerned about spending money with their health savings accounts. So I don't want to give I just want to point out that private insurance is not the panacea, and that there are many children with private insurance who I think are getting lower quality care than children who are enrolled in Medicaid.
To be clear, I wasn't saying that about Medicaid.
Oh, no, I know
Medicaid is just such a big player. You know, half of births at least in the US may be increasing, and it is a critical partner in care and provides excellent services like EPSDT. Medicaid's critical, and I think it has to be part of the solution.
Yeah, it's like 65% or so of all children.
And I didn't mean to throw Colorado pediatricians under the bus. We don't have.
You're going to have to answer to them.
We're not the burning. We don't have the burning platform. We're a low lead state.
Yeah.
So it doesn't mean we're a no lead state. So that's the issue that we are always facing. All right. So let me turn to our org reps. Oh, sorry. Oh, Jennifer, I'm sorry. And then Jeff.
That's okay. I just wanted to kind of come to Colorado pediatricians' defense. I think that I was just really struck by how wonderful Dr. Kemper's data looked, but I think that you also have to recognize the circumscribed scope of the clinics that you're describing, as opposed to a statewide, look where you're bringing in, like rural areas that are quite far from, like even a pediatrician, right? Their pediatric care comes from an advanced practice provider who is affiliated with a family practice group, et cetera. So I think that that's just one of the things I wanted to throw out there, and that it's those disparities and all this fragmentation, as Dr. Patrick pointed out, in Medicaid services and even in what private insurers will cover, that really makes it difficult to standardize what we want, early childhood care to look like.
Thanks, Jennifer. Jeff?
So one of the reasons why we asked Stephen and Alex to do these talks, it answers some of the questions that keep coming up. So for example, we heard just today from Deborah and Susan and others, how is the system of care meeting the needs of all kids, right? Because that is something we have to be concerned about. And I'll give you at least one example. Connecticut's a small state, but at least it's statewide. And they presented a couple years ago, we should have them back, where they link their newborn screening positive results to, and they have a contractor at Connecticut Children's Hospital that works with Yale. And they have demonstrated over the last few years that pretty much every single child with a newborn screening result is being followed up across the state. And in terms of following clinical guidelines for sickle cell, hypothyroid, and a few other things, they're making dramatic gains, about 20 points over the last 2 years. And have shown at a population level how if you have the proper systems, all the things that Alex mentioned, you can have a huge impact. So there are examples around that do that. The other reason why we had you guys doing these talks, and this has to do with what Michelle mentioned before about we are the advisory committee for newborns and children, and that sometimes we get so focused on the state public health lab approach that we forget there's a whole range of other things. And so Alex, I'm going to actually ask you, and you had that slide that had the well child care screening and surveillance and newborn, public health screening. And I wonder if it's less of a clear contrast and more of a continuum. Right. So we've heard examples. Well, okay, if it's a state mandate and the dry blood spot goes to the lab, we're pretty universal, but not a lot of shared decision making. But then, as you pointed out, Stephen, in the newborn period, almost every baby is going to get antibiotic ointment in their eyes. They're going to get a vitamin K shot. They're going to get glucose checked. So there's a whole range of things that happen pretty universally. And as you get to vaccines at 2 months of age, we're really good. As you get to vaccines as an adolescent, it drops off. And it's more of a continuum. And so one of the things for us to think about is what's the best place for screening? Is screening part of a state public health mandate? Or does it fit better as a hospital protocol standard of care? Or does it fit better as a clinical practice later on? And we asked them both to talk about quality improvement to show that there's clearly a drop off in equity, but there are ways of addressing that and making it better.
Thanks, Jeff. All right. Again, I lost track of the order, so I'm going to go reverse order and start with Deborah.
Do you want me to comment on that? I mean, I can comment. I agree.
See, I knew you did.
There we
Deborah?
go.
So I have a number of comments. So I'm going to start out with one that is totally not evidence-based driven, but when Texas went to implement its CCHD screening, before the state mandate went into effect, the hospitals were using it as a marketing tool. And it greatly improved the number of kids that were being screened before we even, were officially required that screening. So there are other ways. A couple of things on the pediatricians. There are ways to impact things, like there are lots of AAP runs, lots of ECHO projects, which is basically educating the physicians to help educate the folks around them as well on any given issue. And a lot of also other QA projects are when I know that there have been times when we couldn't do things as a state, but we turned it over to our maternal and child health or perinatal collaboratives and asked them to take things on as a QA project. And that really, some of them they didn't take, and some they did, and some of it really impacted that and improved that quite a bit. And so I think that there are lots of levels for intervention and there are lots of creative ways to incentivize things. And, in terms of the EPST, the early programs, my understanding is that in Texas, that if the pediatrician does not check all the boxes, they don't get paid. That's a big carrot and stick approach. And so everything on there has to be done before they get their reimbursement for their visit. I don't know if that's true in other states as well, but that was my understanding of the way it worked in Texas. So yes, everything got done. But it was a lot of the things also were approached as QA projects, and they were, when the state was unable to do it themselves, we reached out to our colleagues and we had some incredibly committed pediatricians and champions that helped work throughout the state to make certain that those QA issues were incorporated. When we couldn't do it as a mandate, it went over to QA projects.
Thanks, Deborah. Bob?
Robert Ostrander, American Academy of Family Physicians. I got pulled into this world in 2002 when my practice got chosen to be part of DitchQ's medical home learning collaborative for children with special healthcare needs, and it slowly morphed into genetics involvement. But that was a very early effort to spread the notion of short cycle change in PDSA cycles. And I know you both talked about these, and my comment is more generic about what happens when we don't do the study part of PDSA, because that's what I've seen has been the big problem on a couple of levels in my life. And one is the smaller hospitals that may not be as sophisticated as yours. And the other is legislation, where the original change isn't circumscribed either in terms of time and number, and there's no pause taken to study and decide what you're going to do. I give a lecture on this to the fellows at Rochester, or was at least for a while every year. Sometimes it should simply be abandoned. Often it should be modified. Sometimes it should be spread and done in a larger way. But what I see is, outside of sophisticated programs like yours that clearly are doing exactly what they're supposed to be, because you're monitoring your change, and those graphs show these nice little stepwise improvements, or a stall and then a bigger improvement because they've done that, is making sure that people do that stop, study, and then modify, because so much gets put into place that is either poorly designed or actually negative. And again, legislatively, part of that's my own bent on the wrong people telling us what to do, and then again my small institutions, and we end up having work added and check boxes added to our day that keep us from doing the stuff we need to instead of improving care.
I want to just respond to one thing real quick, which is the notion of how do you do quality improvement in small, under-resourced environments. And there are really good models for that. State perinatal collaboratives do that very well. It's generally one volunteer, often a nurse who volunteers at a level 1 hospital. We've seen birth hospital who may have a small volume of births. But that's where the structure of perinatal collaboratives is so extraordinary, because it provides an infrastructure for federal support and then at the state level that includes a lot of volunteers at these small hospitals to prioritize, okay, what do we want to improve and where do we want to improve it? And state perinatal collaboratives have been incredibly successful at driving statewide change, from everything towards early term deliveries. If you remember that, when we were delivering babies early before 39 weeks, and it's not even talked about anymore because of state perinatal collaboratives. So we can do this, and there are good examples of it. I would agree with some previous comments, which is the hospitals are where the babies are, but we can drive positive change at hospitals, and we can do it in small rural communities if we right size it to what the needs are of those small communities.
And if I can build on this too. So one of the things that always upsets me is that when these quality improvement projects all fall on the clinician, the pediatrician or the nurse practitioner to be the agents of change. And, if you can only work harder and check these boxes, then things will be better. I would say that the biggest improvements that we've had have been things that have been completely outside of the clinician, that has actually made the clinician's lives better. So when I showed you the dramatic improvement in early well child visit rates, all that was done based on having the, when families checked in, getting their subsequent visit scheduled as they check in for their current visit. So there's like small things that you can do that can make a huge difference, and it can't all fall to the pediatrician, the nurse practitioner, or whoever to do everything.
I'm just going to answer big. I think that's one of the key lessons that we learned even in that original learning collaborative. The people at NICU brilliantly set that up with a physician, a staff member, and a parent partner. That's how that was run, and it became the model for our small 3-physician practice. And we made all sorts of, like you said, a small size can be wonderful if people know and if we stop. I think the very last one I did, or nearly so, before I retired from day-to-day practice, was one to get the EMR to prompt us to see if the newborn screening results were back at the 2-month follow-up.
Yeah, those are great examples. It's a great example.
Sabra.
Thanks. Sabra Inkner from Association of Maternal and Child Health Programs, which I would just like to shout out as your resource for these things. Your Title V and children with special health care needs programs in all of your jurisdictions exist, and would love to have this conversation with you, as that is very much part of their programmatic mandates, is all of these things in driving. They have to report metrics on on many of these things, and would very much like to have additional partners to work on them with. They're always at the table with PQCs, with EMSCs, with many of these programs. I want to just flag a couple things that I think we've talked about here, but we glanced upon. One is screening without knowing what to do with the result is a real problem, and I think that is a lot of when you get resistance to running a test, to collecting even a blood lead level, is what am I doing with this? Do I know how to interpret this result? Do I know what I'm doing with the result? And a lot of times the answer to that is no. So it really has to be much like we know the consequences in the blood spot screening world of I don't know what to do with that information. That goes for all screening. That goes for developmental screening. That goes for behavioral health screening. So keeping that in mind, and I did write with AAP a 7 or 8 page guidance on developmental screening for non-clinicians, for folks that are doing that in the public health space. So those resources do exist on that. And the other thing that I want to say is that I've been thinking a lot lately on when does newborn screening begin? And I think CCHD is a perfect example. I was recently having a conversation with a fetal cardiologist who really gets upset when somebody is identified on the CCHD screen, right? They want everybody diagnosed, identified essentially in utero, right? They want them all at the 20-week ultrasound, which is a screening, right? The 20-week ultrasound does not find out the gender of your baby. It is a screening. And that, the quad screen is a screening. And that maybe it is really time that we start thinking about screening as something that occurs across the lifespan, that begins in the perinatal period and extends on, and really consider them as all part of one package, and not just this one point in time at 24 hours when we do something.
Thanks. Amy? Oh, you took it down. Okay.
Oh.
Well, I really appreciate the presentations. Thanks, Alex, and thanks, Stephen. I have a real interest in thinking about newborn screening recommendations and specifically around how we might create recommendations that don't require state laboratories and state programs to do things that they can't do or are unable to do, but still support the basic screening where early detection will lead to better outcomes over time. So it's kind of almost it gets right back to the kind of public health readiness and ability to do screening and trying to expand beyond what you can do with the dried blood spot more systematically to what you can do in the system for these point of care delivered tests that that will be or are currently associated with improved outcomes because of early detection. And going further back into the prenatal care period is kind of an interesting concept as well. So I appreciate the dialogue. I hope I know I learned a lot. I appreciate the issues that we talked about and now you kind of understand a little bit about why we have an acute interest in exploring this a little bit further as a committee. So I appreciate the time. It's been an interesting day. And we have a really great session tomorrow. We're going to consider a nomination package and hear about the assessment of the package and have a motion and a vote about potentially moving that on to full evidence review. So I look forward to public comments tomorrow and hope everyone has a good evening. There is a session for organizational representatives orientation. It's in room 5N54, which is on this floor. It's that way, that direction behind you. And I'll look forward to seeing the interested org reps there for that session. Otherwise, I hope everyone has a great evening. We'll see you tomorrow.
And I have one additional announcement. And I'm going to make this announcement tomorrow also. The November meeting, so the meeting scheduled for November 14th through the 15th will be virtual only, no in person in November. Thank you. Have a good night.
Thanks, everyone.